हमारे पास
तो आप चांडालिया सर को म्यूट कर दो।
या
किसमें फिर
various aspects of this could be actually imparted in a more scientific and a rational manner. Ladies and gentlemen, being a teacher all my life, I can go on for hours, but I know the basic principle of webinar is that you have to stop short before others go off to sleep because you don't even know whether the audience is listening to you or only talking to yourself. Sometimes the connection also goes off.
Hello.
So, before I end, I would just say that the time when the whole world, at the time the whole world is engaged in the fight against COVID, and India, under Prime Minister Narendra Modi, is leading from the front. We are currently running one of the fastest vaccination drives in the world for the very first time.
तो दस्तखत करा ला है तो
People were vaccinated when this drive is launched.
मैं 6 बजे बेटा हुन मैं घर आ जाया था
And we are sustaining this
वाली गली च
despite the constraints
हां
of a population of 135 crore. And at a time like this, it is an opportunity for all of us in Diabetes India, and indeed for all of us in the diabetes fraternity to contribute our might to defeat this menace. Thank you very much, and thanks also for making me a part of this beautiful event. But I'm sure next time it will not be virtual because Bansi has escaped without even offering a cup of tea. Otherwise, we would have looked for grand banquet, if not two, at least one in the city of Ahmedabad. Yes. Thank you very much.
Thank you, sir. Thank you, Dr. Jitendra Singh. And as you were talking about diabetes COVID webinar, even in this meeting of World Congress of Diabetes India, there is a dedicated symposium on COVID and diabetes. And in the last few months, Dr. Arvind, Dr. Shashank Joshi, Anup Mishra, we all organized multiple such meetings, and we will definitely take it forward, and we will have dedicated meeting on diabetes and COVID by diabetes. As we move towards the end of this inaugural ceremony, it's my great pleasure to pronounce vote of thanks as an organizing secretary of Diabetes India 2021 and also as a secretary of Diabetes India. First and foremost, I would like to thank Almighty God for blessing us all, bringing all of us under one platform today on this auspicious day. I humbly thank our chief guest, Dr. Jitendra Singh Ji, Minister of State, Government of India, for being here in spite of his busy schedule in this pandemic situation. I humbly thank our chief guest, our guest of honor, Dr. Andrew Bolton, but we missed him. Today he could not join. I thank our guest of honor, Dr. Akhtar Hussain, who is President-elect of International Diabetic Federation, for his gracious presence during this inaugural ceremony. I thank Dr. Shashank, Dr. Anup Mishra, our President, Dr. S.R. Arvind, Joint Secretary, Dr. Sanjay Reddy, Dr. Amit Gupta, and all other members of organizing committee, as well as all the members of scientific committee for putting up a wonderful scientific program. I must thank all our international faculty who are more than 16 number for giving their kind consent for being virtually present for this our annual congress. I also thank all our national faculty that in spite of their hectic schedule in current situation, they agreed to be part of this conference. I thank all international supporting organizations, American Diabetic Association, European Association of Study of Diabetes, International Society of Pediatric and Adolescent Diabetes, SPAD, CODI, ATTD, International Hypoglycemia Study Group, Diabetes Education Study Group, Diabetes Asia Study Group, Primary Care Diabetes Europe, PCD, Indian Academy of Diabetes for being partner in this conference. I thank all our industry partners, particularly USV, Torrent, Sanofi, Novo Nordisk, Eli Lilly, Abbott, Boehringer, Microlabs, Dr. Reddy, and all others for their generous support in organizing this conference at such a large scale. I thank our event management company, RS Events, for providing wonderful platform in this pandemic time that we all could connect in spite of staying distantly physically. I would like to thank my team DiaCare for helping me in all administrative work for this conference. Before I end, I would like to thank my family, my wife Annu, my kids Ria, Jisa, Meet for their constantly observing my absence while I was working for this conference. At this juncture, I would like to remember my teachers whom we lost recently. First, Dr. Shaukat Sadikot, Dr. O.P. Gupta from Ahmedabad. He was patron for RSSDI, and Dr. Siddharth N. Shah, though we have lost, but your wisdom for people with diabetes in this country will be carried forward by the diabetes community in India. With this, I conclude this inaugural ceremony by thanking everyone who worked very hard for this conference, and kindly forgive me if I forget to mention anything. Can I request everyone to rise for the national anthem? Hardik, चालू करो. Neelam, start. जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जाने तव शुभ आशीष माने गाहे तव जय गाथा जन गण मंगल नायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे जय हिंद. Thank you very much. Once again, thank you, Dr. Jitendra Singh ji. Thank you, Dr. Arvind. And thanks to everyone. Now I think we all can join. Those who are faculty, please join as a faculty and please join as a delegate and enjoy the wonderful platform. Thank you very much.
Thank you, sir. Thank you very much.
And thank you, Bansi.
Vishal, am I audible now?
Yes, you are audible.
Yes.
Oh,
So I
let me.
think
Hi,
let me
bye.
start now. So once again, good afternoon, everyone. And today we start with our session Diabetes Care Symposium. And for this, I would like to invite our chairperson, Dr. Vitul Gupta and Dr. Bharat Sabu sir. And I request to over to Dr. Bharat Sabu sir to chair the session, please.
Thank you, Dr. Akash. First of all, I would like to thank organizing committee of Diabetes India for giving me this opportunity. I would also like to thank Dr. Vitul Gupta sir for being my co-chair. And I would like to thank all the speakers for giving their precious time for this event. I would like to request Dr. Vitul Gupta sir to introduce Dr. Hemraj Chandalia sir. Can you put on the slide for Dr. Chandalia, sir, please?
I think we need to change the slide of the chairpersons and yes. So I am very lucky to introduce such a senior person. I think he doesn't need any introduction. Everybody in field of diabetes knows him. So if I try to describe him in few words, it will be injustice. So I'll like Dr. H.P. Chandalia to please proceed with very important aspect of diabetes to review diabetes treatment from ancient time to the present. So Dr. Chandalia, please.
Yes. Thank you very much, Dr. Vital Gupta and Dr. Sabu. My thanks to Diabetes India for inviting me. This is after many years that I'm able to come for this meeting for some reasons which are difficult to discuss right now. But anyway, my subject today is from ancient time to the present. And I realized that this ancient time has been overdone, you see, already. There are several sessions are done where I've taken insulin for 100 years and all. So now I've taken a totally different stand. That is what I will discuss today is about 50 to 55 years of diabetology that I have witnessed personally and some places getting involved in giving it a little bit shape here and there. So I think that will be more interesting for the listeners because this applies to the present treatment approaches that we take. And remember that we always discuss materials like new insulins, new oral agents, when we discuss history. But remember the thought processes that go behind our practice guidelines and how we go have developed over a long time. And of course, last 55 years, they've been developing vigorously and changing at times to a completely different approach. So I'll discuss that because that would make a very interesting, I think, listening for all of you. So can I have my slides, please? I'll share from here my slides. Can you permit me to share the screen? Yeah. If you can remove from your side my slide. Just allow me to share the screen, please.
Technical team, kindly stop sharing your slides so that sir can share the slide.
Yeah.
Hello?
Yeah. Now I don't see the green button. Yeah. Can you go back to the previous mode where I can get that green button and proceed? Can I? Is someone helping me? Technical?
Yes, sir. Yes, sir. Tell me.
Yeah.
Sir, on your Zoom screen, there is a green button, if you can see.
I don't see it now. I saw it earlier when the slide was there. You know?
Sir, so on your screen, there is a mini Zoom button there. So click on the full screen. Click on the Zoom full screen.
You want to load your presentation?
On the mini button, it says press here.
For what?
For
Sir,
sharing.
open the Zoom full screen. On the full screen.
Okay.
Okay, now you can see the green button. bottom of your screen.
Yeah, I think. Yeah, I can now I can share. I got my slide.
Yes. Okay.
Yeah, okay, great. Thank you. Yeah, okay. Good. I think we proceed. Okay. 50 years of diabetology, frankly speaking, 55 years. Obviously, I'll take it together with my 55 years of journey of diabetology, and I'll go very rapidly because some of the concepts are known, but I'll try to bring out historically how they change our pattern of practice. So very early, what were the drugs we were using? We were using really tolbutamide, chlorpropamide, and insulin. And insulin was the dirty insulin, what we call with 8% impurities, quite often a beef pork mixture. And that is the time this study was done called University Group Diabetes Program, a celebrated study, but highly criticized, in volumes of books. This study was comparing sulfonylurea, which was tolbutamide, and fixed dose of insulin versus placebo, of course, and trying to see the outcomes. So this is one of the very early studies which did the outcomes, whether there were more cardiovascular events or what kind of outcomes will occur in these mainly two active arms, tolbutamide and insulin. And it was found that the tolbutamide group did very badly. As a matter of fact, there were a lot more cardiovascular events there.
Sir, sorry to interrupt you. Your screen is not visible. So once you close your stop screen and then close your PPT, then reopen the PPT and then
close my PPT. Okay.
Close your PPT once. Then stop screen your screen.
Wait now. How do I close this? Stop share. Okay, stop share. I've done that. Okay.
And close your PPT once, then reopen your PPT.
Oh, okay. PPT. Wait, my PPT is here. Yeah, I'll have to close it. Okay. How do you do that? I have to close and restart from beginning.
Why?
I don't know. There are some glitches.
So, sir, sir's slide is maybe hanged. So
yeah, this
it is not visible
started.
to us.
I started. So it's not visible. I don't know why. Share again. And we need to close this.
1 second.
Yeah, escape. Yeah. Okay, close. Okay, we'll restart now. Yeah.
Slides.
Yes, sir. Now it's visible. Make it full screen.
Yeah, make it full screen. Okay, I think we go rapidly. We lost in this. We always praise the technology, but we are slaves of technology and we lose about 6-7 minutes precious in that. Anyway, so I think we proceed. So this study showed the sulfonylureas can be detrimental, especially the first generation like tolbutamide, which was used. And of course, I must tell you that subsequently sulfonylureas have been compared. And the newer generation, like glipizide and menclomide, neutral, and glimepiride and glycoside may be beneficial in cardiovascular disease. So I think this is where the sulfonylurea stand. So currently, all of us know that we primarily use glycoside or glimepiride. I really use glycoside far more extensively than any other because obvious more cardiovascular benefits. And I use the plain form in small doses 3 times a day in order to avoid hypoglycemia. Now, then came a very important concept, which was not existing 50 years ago. It was developing about 55 years. You see, when I received my training in US at that time, this concept was developing. This concept is that of insulin registers. Initially, diabetes was always thought both type 1 and type 2 as insulin deficiency disease, but this was an important concept which we take for granted currently when we approach treatment of a type 2 diabetic. And this was possible, one, because the RIA of insulin was described. This was described, you see, somewhere around 64, 65. And my training in US started in 1967. At that time, Gerald Reaven had described that the insulin levels are elevated in diabetes and in obese people. And many other investigators did that. This was all possible because of Rosalind Yellow and Burson, who described this method in around 64, 65, and she received the Nobel Prize. Remember that insulin was the first protein molecule which was measured in such minuscule amounts. So this is the honor for this. This is a small way in which our center participated in developing this concept. And this is a publication in American Journal of Clinical Nutrition with my professor, me and my colleague there in US. This was the largest volume of insulin assays done at that time. Insulin assay was not as easy as you do it now. In fact, you had to really inject guinea pigs and raise your antibodies yourself. And you had to label the hormone yourself with radioactive iodine. So all this, some of us have done because we have done the assays at that time in large number of assays. And this paper, preceding this was a paper in New England Journal of Medicine by my professor and his colleagues. At that time, I was not at the center where the hyperinsulinemia and obesity were described. This particular paper is almost one of the very early ones, which in large number of people showed that the insulin levels are raised even in non-obese impaired glucose tolerance group. There was no word like impaired glucose tolerance at that time. This semantics came much later on. But you see, at that time, we used to call it borderline diabetes, or many such epithets were used. And in that, I think, you see, we realized that even lean people with borderline diabetes and hyperinsulinemia. And that means the concept of insulin resistance came thereby. And this is an important concept clinically, because treating type 2 diabetic without addressing the issue of insulin resistance, it will be always doomed to failure. You cannot get good results. Even you give multiple dose insulin therapy in type 2 diabetic, you will sensitize them by some sensitizing agent, and then only you will meet success. Then came two very interesting studies, which nowadays we don't consider very important because they are overshadowed by a lot of modern studies. But they were really landmark studies, DCCT and UKPDS. You see the years there. I must tell you that in the medical profession, prior to these studies, quite often there was a therapeutic nihilism. That means no action. Hyperglycemia was sometimes considered benign. Patients were told that 200 is your normal sugar. See, those kind of concepts were prevailing. See, so these two studies nailed down a very important concept, and that is that hyperglycemia must be controlled. And control of hyperglycemia will improve outcomes. So this was very important that these two studies did that. DCCT in type 1 and UKPDS in type 2. And you see the importance of glycemic control came because of these studies. And incontrovertibly, thereafter, everybody accepted. For example, cardiologists will often tell me at that time that diabetes is not important to control. Why are you wasting your time? You have to control blood pressure and high LDL cholesterol. And that is really the key to prevention of cardiovascular disease. But this, of course, proven that hyperglycemia was important. And of course, role of some comorbidity came in UKPDS in a beautiful way. That is hypertension control. The hypertension control gave even greater benefit, a little bit marginally greater benefit than even glycemic control in this study. And therefore, there came the concept of controlling the comorbidity, which was also a very important clinical concept. Some of us have had CMEs, like I conducted some CMEs almost around that time, whole CME of 2 or 3 days on treating comorbidities in diabetes. So we started focusing on hypertension, cholesterol, and tobacco cessation strategies. Another very interesting concept was regarding cardiovascular complications. Steve Hafner, a very well-known person at that time, a lipidologist and a great physician. And he floated this concept which prevailed for many decades. but it is slightly modified now. It is assumed that a type 2 diabetic at the time of diagnosis is itself a risk, like a person who has suffered from one episode of myocardial infarction. So his chances of getting second myocardial infarction is the same as that of a non-diabetic who has suffered a myocardial infarction. So it was called a myocardial infarction equivalent. There are exceptions to the concept I want to bring out to you, because all these are in a fluid state. I must tell you that I always quote this Bertrand Russell, the great mathematician, philosopher, that science is always wrong because it disproves tomorrow what it proves today. But what it proves today is important, and that is what we go by. And here is the study of Steve Hafner showing that if you see the first and the last, you see that they both are equal. So non-diabetic, you see, with myocardial infarct is equal to a diabetic without myocardial infarct. So this concept prevailed. It did duly emphasize the importance for diabetes in producing the cardiovascular disease, but it was not always true, because newly discovered type 2 diabetic probably do not face the same risk. So this is very interesting study I came across, which is not often discussed, and I find it very interesting. This is follow-up of 1.5 million patients by a health provider group like Kaiser Permanente in California. And they had about 80,000 having cardiovascular or coronary artery disease. And there you see the coronary artery disease alone. You see diabetes alone, what was the risk hazard ratio? And diabetes with coronary artery disease, what was the hazard ratio? And you will find that, you see, the cardiovascular risk equivalence was not ab initio in type 2 diabetics, not at the time of diagnosis, but it came subsequently. And this follow-up in this study shows that it comes somewhere after about 10 years of type 2 diabetes, that the risk becomes equivalent to that of a person, you see, having myocardial infarction, non-diabetic myocardial infarction. So initially type 2 diabetes, although theoretically we have seen cardiovascular disease even at the onset of that, like UKPDS, newly recruited, newly diagnosed patients, had some retinal changes, little bit microalbuminuria somewhere, all that. But truly, the real onset of cardiovascular disease is after 10 years. So I think this is very important. There came another very interesting concept in our practice, and that is this very, very interesting paper of David Nissen. And he described that with rosiglitazone, the outcomes, there was cardiovascular increase in cardiovascular event. This changed the whole picture. We became so conscious of cardiovascular event, which was very correct thing to do, because that is what really kills the diabetics, you see. And we all started focusing on that. And then all the regulatory authorities then came up with the idea that any drug that is used in diabetes, especially the newly introduced drugs, have to prove that they do not increase cardiovascular risk. They are neutral to the extent that at least maximum allowed was 0.3, you see, hazard ratio increase, that is 1.3 ratio. But beyond that, if it is there has to be a trial for cardiovascular outcome. And this is the result why you see those multiple cardiovascular outcome trials at present with the new molecules. And what really I have to sum up quickly, because for the sake of brevity of time, you see that the summary of that, all that those is that if you think atherosclerotic cardiovascular disease, if you see the progression of renal disease and of course heart failure, these three things have been seen very, 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 very closely now with good studies. And what really came out of that, the gist is here, on the basis of which now we practice and we select our therapy in our diabetics. And that is first generation sulfonylurea we avoid. Neutral is second generation and third generation sulfonylurea. Insulin has not shown benefit, but is neutral, and DPP-4 inhibitors are largely neutral. There are little bit exceptions here and there, but this is the broad consensus. The borderline benefits, metformin is still being looked at as a beneficial drug for cardiovascular system. In UKPDS, it came out to be quite a winner drug in reducing the cardiovascular disease. And pioglitazone, there is some evidence may do that to some extent. But most important star drugs there are SGLT inhibitors, which you know will work both for all these three situations, and GLP-RAs GIT receptor agonist, which will work for atherosclerotic cardiovascular disease, but not necessarily for the progression of renal disease and heart failure. So the approaches we take are based upon these evidences and these concepts. Hypoglycemia is always the main barrier to controlling diabetes. Otherwise, frankly, anyone can control diabetes with the powerful tools of lowering sugar we have in our hand. So how do you reduce? You see, hypoglycemia and get good A1C is a big art. And I think we all are honing that art continuously. And I'm doing that for the last 55 years. And now I think that last 5 or 7 years, we have been blessed, because now we have started using a lot of oral agents which do not produce hypoglycemia, like not much hypoglycemia, like DPP-4 inhibitors and SGLT2 inhibitors. And of course, metformin also comes there. So you use these agents more and more. And by that, you can lower the A1C much better than before. And the goals of A1C that we achieve are getting better and better as we go along. See. I'll go a little rapidly. Okay, so I think now, more often we use now, I sometimes classified, although such classification is only conceptual, that is there drug which cause hypoglycemia and drugs which do not cause much hypoglycemia. And most of us now use these other drugs on the anti-hyperglycemic side, you see, in controlling our diabetics. If at all we use a hypoglycemic drug like insulin or ripaglinide or sulfonylurea, we do not combine at least 2 of them in one patient. And by doing this is a very smart strategy that we all have learned now in controlling diabetes, type 2 diabetes much better and reaching nearer to much better A1C. Now we are analyzing some results of last 2 years, and now we are going far below 7 very easily. We are going to 6.5, 6 in a large number of patients. There's another very interesting concept came based upon these TRIO studies, Advanced Accord VADT. Many of you heard about those studies. These studies showed something very, very interesting. That you see, the tight control of type 2 diabetes is beneficial in the early stages. So I would say first 5 years of type 2 diabetes and maybe 10 years. I call it golden period in diabetes. Cardiologists have golden period of 30 minutes for myocardial infarction, but we have a golden period of 5 to 10 years. And it will be a shame we don't utilize this golden period in controlling them very well. But it is harmful if you do that when complications have developed, cardiovascular, renal, retinal complications have developed, and you are pushing therapy very hard, like it was done in these very famous studies. Weight gain is an important concept. All the time we are discussing weight gain. Most of the drugs are looked at from this point of view, whether they cause weight gain. And insulin and sulfonylurea notoriously will cause a lot more weight gain. But we looked at it differently. I published a paper some time ago showing that in our patients, weight gain were primarily confined to patients who had lost weight prior to instituting good metabolic control. So it was really a catabolic state which had produced weight loss. And that weight came back. And quite often they came back to the baseline weight which they have held for many years. So although we attribute all weight gain to insulin therapy, but it may not be really true. Good amount of it is really the recovery, and it reflects only the anabolic state created by insulin and restoration of health. Insulin pumps, we started using insulin pumps very early, very early. I was one of the very early users of pumps. Now I have a group of patients who have used pumps for 20 years, 25 years therapy. You see, and some of them beautifully managed without any complication. I delivered type 1 diabetic on insulin pumps, pregnancy, maybe more than about 10 or 11, and a couple of them 2 times. So I think we have this use of insulin pump has changed the whole thing to my mind. We have not used them as much as we should use. Apart from cost consideration, they are wonderful tools, and now they are almost getting automated. For example, the basal insulin supply is almost getting automated soon now, or almost done in some new models. And the meal-related insulin, of course, automation is a difficult thing, but it is being looked at very, very carefully, and I'm sure it will come. And here you see, I gave an oration in RSSDI's meeting, Sam Moses oration. And it was 1982 on my pump patients in New Delivery Systems. I talked about pump in 1982 at that time. And then we ran a workshop in Delhi for insulin pump therapy, teaching a lot of physicians on that, a few hundred physicians on that. Dr. Ahuja was with me, Dr. Pfeiffer from Germany, Dr. Joship from US, and Dr. Mecklenburg from US. We were all on the faculty, and I convened this insulin pump workshop. And I think the pumps are being used by 4 or 5 centers in India extensively, including ours, where we have about 55 patients or more on pump for a long, long time now. Monitoring control, we keep discussing A1C, SMBG, CGMS. I won't go into details of that. We were involved in, of course, establishing A1C as an important monitoring test in our country. And this was 1980 that our first paper came shown here. Then we had a spate of publication, as you can see here, on A1C. And of course, we developed newer methods. We developed methods which were tropicalized and could be used in India with a lower cost. But slowly, of course, modern technology has overtaken all of those methods. Yet some of these are very important. At that time, we also visualized that this can be used for diagnosis. So one of my very early presentations is on diagnosis of diabetes, which you know now is well accepted that estimation of A1C is a better tool to diagnose diabetes. So this is very well established now, but this was thought of us by more than about 30 years ago that it would serve as a very good diagnostic criteria. So you see some of these developments. I have really taken you through some of the very important concepts. I really can't go further for want of time, but frankly, similarly, there are many other 5 or 10 very important concepts and research papers which have really guided our approach to therapy. And I think they should be discussed more often than the simple history and chronology and all that, because that, I think, to my mind, will be extremely boring to you all listeners. So thank you very much for your patient hearing. And if the chairpersons permit, I'm ready to take a few questions. I think if you minus the time which went on starting, I finished in time. I timed it with my timer. Thank you very much.
Thank you, Chandalia sir. You did it to perfection, actually. So we are very thankful to you, Chandalia sir, for depicting this beautifully, the journey from the RIA to the insulin pumps and how it has changed the perception and the prescription behavior of us. So Dr. Gupta sir, any questions for Dr. Chandalia sir?
No, sir, I think that is the disadvantage of technology sometimes, that we sometimes waste on technology, and technology is sometimes efficient in improving our performance also. I think I must congratulate Dr. Nalia for briefly discussing the whole history, and especially listening from the person who has experienced such things. So that is very, very important. Now we see obesity and metabolic syndrome. Insulin levels are done so easily, and back then when you were there and researching on insulin levels, it was so difficult.
Yeah.
So thank you very much, sir, for giving us an insight how, and it is really good listening from a person who has experienced himself. Thank you, sir.
Thank you. Thank you very much.
Thank you very much. Can we have the intro slides for the next speaker, please? With your permission, Gupta sir, can I?
Yes, definitely. Please go ahead.
It gives me immense pleasure to introduce Dr. R.M. Anjana, who is a Managing Director of Dr. Mohan's Diabetes Specialties Center and Vice President of MDRF. She has done MD Diploma in Diabetology from UK. She is a PhD. She has done her FSCP, FICP, FRCP from Glasgow, Edinburgh, and London. She is a Fellow of Academy of Clinical Endocrinologists as well. Her core research areas are prevention of diabetes, epidemiology, physical activity, and translational research and metagenomics. She won the Young Outstanding Woman Achievers Award from Dr. MGR Medical University. She won the RSSDI Novartis Young Investigator Award, which is given by RSSDI. She won Shakuntala Amir Chand Prize from the Indian Council of Medical Research, ICMR. She has given several lectures and she has numerous international publications to her name. She has been selected as the member of WHF Salim Yusuf Emerging Leaders Program as a world-renowned leader in global cardiovascular disease CVD research. And she will be enlightening us on the new clusters of type 2 diabetes mellitus. Over to you, ma'am. Thank you.
Thank you very much for the kind introduction. Let me just share my slide. Can you stop sharing? Yeah, just 1 second. Can you see my screen?
Yes.
Yes, okay. Good afternoon, everyone. And at the outset, it's such a pleasure to be here today. And special thank you to Banshi Sabu sir, Arvind sir, and all the other organizers of Diabetes India. So I'm going to be talking about the novel clusters of type 2 diabetes. And yeah, I have no conflict of interest to declare. So we start by asking the question, are all type 2 diabetes the same? Are all patients the same? Should we treat them all the same way? Well, the answer to that is of course not. How can a person who is young, thin, and has young onset diabetes be the same as someone who has diabetes with age of onset more than 60 years or is obese or has some other problem? So there are so many differences in terms of BMI, response to medications, susceptibility to complications. And truthfully, today, we do not know what drives these various factors. So the first kind of subclustering of type 2 diabetes, which means that you don't treat all of type 2 diabetes exactly the same, started in the West when they started trying to cluster different types of type 2 diabetes. And this is the first data that came from the Scandinavian population by Professor Leaf Group. And this is what they did. So they studied about 8,000 individuals, 9,000 individuals. They took all diabetes, not just type 2, but they took all diabetes and took 6 variables to study. So this included GAD antibody, age diagnosis, BMI, A1C, and then they had the HOMA beta, which is a function of insulin secretion, and the HOMA IR, which is a function of insulin resistance. So they took these variables and tried to cluster their population. They then replicated these clusters in some other populations, not very large sample sizes, 1,800, 3,000 individuals, etc. So what did they find? They found 5 clusters of all diabetes, of which the first one called SAID is type 1, and we won't talk about that anymore. But among the type 2, they had 4 clusters. The first was called SID, which was a severe insulin deficient type of diabetes. Then they had something called a SIRD, which is an insulin resistant diabetes, severe insulin resistance. Then they had a MOD, which is obesity related diabetes, and a MARD, which is age related diabetes. So this is what they found. So the question obviously comes, can we apply this clustering exactly as it is to the Asian Indian population? So Asian Indians have a unique susceptibility to type 2 diabetes and cardiovascular disease. And I'm sure people here are very familiar with the concept of the Asian Indian phenotype, in which we have younger age of onset of diabetes. So we have data from the INDIAB study, which shows that age of onset of diabetes starts in the age group of 25 to 34 years. Whereas in any Caucasian population, it's 50 plus. So you see a shift to the left with younger and younger people, thinner people. All of us have seen the thin. It's not just that the young person is very obese and is like the Pima Indian with BMI 35, 40 for them to develop diabetes. All of us have BMI 23, diabetes, 22, diabetes. We have the thin Indians. We still have an increase in serum insulin levels. We have a characteristic dyslipidemia, which all of us almost have, with low HDL cholesterol and high triglycerides and high and small dense NDL. We have increase in inflammatory markers and excess of abdominal and visceral fat. So all of these cause an increased predisposition for not just type 2 diabetes, but premature cardiovascular disease as well. So this is a collaborative study between the Madras Diabetes Research Foundation and the University of Dundee, Scotland, and is funded by NIHR. And the study is called INSPIRED, which stands for India-Scotland Partnership for Precision Medicine in Diabetes. So simply put, this is the clustering which they did in Scandinavia, which is the first part of the table, which you can see here. And this is applying this directly to the Asian Indian population as such, using the same variables, same method, etc. So in the SID population, as would be expected, they are the thinnest people, whereas the insulin, the obese group is the most obese in this population, right? And you can see A1Cs are highest in the SID group, best in the MARD group, etc. So the HOMA beta is kind of very less in the deficient groups and very high in the SERD groups. So all of these are what we try to replicate. Now you move this exact same thing into the Indian population, what happens? So it starts off with BMI. So the BMI, the lowest BMI was for the SID group, but look at what happened to our BMI. Our obese people were not obese at all, actually. They were quite thin with a BMI of 25, and the SERD had a higher BMI, our MARD had higher BMI. So there were issues right from the beginning. Now, if you look at the HOMA beta, you will see that the least is for MARD, but instead of the insulin resistant group having the highest for us, it went to the MARD. So you can see that this clustering is not sitting very well in our population, or suffice to say, we couldn't replicate the exact same thing in our population. So what did we do? This is a new clustering of our own, and this was published in BMJ Open in 2020. So this is what we did. We took patients from the Dr. Mohn's Diabetes Specialty Center. We had 19,000 individuals with new onset diabetes and duration less than 5 years. For the clustering purposes, we took the following variables, and these are dependent on the Asian Indian phenotype. So we had age at diagnosis, BMI, waist, which is very important considering the visceral adiposity of the Asian Indian. We put in A1C, of course, triglyceride and HDL, which is for our population, and then C-peptide, both fasting and stimulated, as a measure of insulin reserve. So these were the clustering variables, and these were the subgroups that we found. So we were able to replicate the SID group, which is the severe insulin deficient group. And we were able to replicate the MARD group, which is the age related. So these two were similar to what was shown in the West. However, we have two new groups, novel groups, which have been described for the first time in the world. And this is the IROD, which is the insulin resistant and obese diabetes. So for us, the obesity and the insulin resistance are going together. We are not able to separate them out in our population. So we have a deficiency, we have a resistance, and then we have a new thing that's called as combined insulin resistance and deficiency. So this is a combination, it's very unique for our population. Actually, the prevalence is quite low. It's only 12% of all the clustering that we did. But as you will see when you go on, this is a kind of deadly group and is prevalent in our population. So just to take you through how we did the clinical clustering. So when we did our clustering, we found that the age of diagnosis for MARD was 50 plus years. So someone was just asking me, I think yesterday, and saying that 50 years is coming into MARD. It's 65, isn't it, according to WHO? But unfortunately, remember, these are people with diabetes, and we have a shift to left for all our ages. We start early. So even our MARD is at 50, 55 years is the beginning of our MARD. BMI, as you would expect, is lowest in the SID group and is highest in the insulin-resistant obese group. Similarly, for waist circumference, you'll see the glycated hemoglobin is high in the insulin-deficient groups, which is SID, of course, and also the SERD. Now, here start the problems. Now, this is a combination of insulin deficiency and resistance, remember? So here you have a high A1C. You have a high triglyceride and a low HDL, with the best HDL coming for the MARD group. So those are the elderly group. And you have the C-peptide being lowest in the cluster 1, which is SID, and the highest in the IROD. So we now have 4 distinct clusters, which are actually following certain kind of characteristic phenotypes. And that's what we found. Just to show you male-female differences, I'm not going to go through these in details, but just to tell you overall, there was not much difference between males and females. The cluster remained stable. Remember, I said we had new onset diagnosis with duration less than 5 years. So we did sensitivity analysis. What happens to 3 years within onset, 1 year within onset? We tried to kind of do all the reclustering, and the clusters remain stable and replicable. But then the biggest criticism that we had is that this is from a private institute, of course, across the country, but it's still from a single institute. So can this then be applied to the population of India? So we then took the ICMR INDAD study, which is a national database on diabetes and its complications in India. We had 6 of the 8 variables which we used for clustering. So we had age at diagnosis, BMI, waist, HbA1c, triglyceride, and HDL. We had all of these variables, and we reclustered in the INDIA population, and this is what we found. So across India here, age of diagnosis was 55, as I was trying to tell you. If you remember the previous clustering, again, SID had the lowest BMI and waist circumference. The highest was for IROD, as you possibly remember from the previous slide. The glycated hemoglobin was high in SID and SIRD, triglyceride, HDL. So it kind of mirrored the entire clinic population, showing the stability of this across the country. And INDIA has data from every single state of this country. So even at a national level, the clusters were replicable and stable. And I'd like to say subsequently, we then received data from RSSDI members. So we have the who's who of diabetology who sent us data, and we've reclustered it in their population with their patients. So we have from almost every corner of the country now, and the clusters are completely replicable. And this paper will be going out for publication soon. So what's the clinical relevance of this clustering? So this is the prevalence of microvascular complications across the various subgroups. So look at the prevalence of retinopathy, and this is where the insulin deficient states become important. The prevalence of retinopathy was highest in SID and SIRD. Of course, nephropathy was high in the IROD group, but once you take kidney disease, you'll see that SIRD, this is DKD actually, by EGFR, and you'll see that the SIRD group had the highest. So it has the combined problems of both the resistance and the secretory defect. Now, if you look at the hazards ratios, so again, here you'll see that for SID, the hazards is 1.56. So this is an independent risk for developing retinopathy for people in the SID group after adjusting for various confounders. And similarly, SIRD had an independent risk of retinopathy, which was statistically significant. For nephropathy, we had in SIRD, and again for CKD, we had a very high number for SIRD as well as IROD. So you can see that the SIRD group has risk of complications. Now, what about reaching target A1C? So obviously the green line is the MARD here. So the best, easiest kind of achievement of A1C of less than 7. Whereas if you look at the deficient groups, both the SID and the SIRD, difficulty in reaching an A1C of 7. So this is the first time in India, or rather in South Asia, that clustering has been done, and we were not able to replicate the Scandinavian or Caucasian clusters as is. 2 of them we were able to replicate, but then we have 2 novel subgroups in our population. One is called the IROD, which is an insulin-resistant obese group, and the important one is the SIRD, which is a combined insulin deficiency and resistance. This novel cluster is characterized by difficult to control hyperglycemia and an increased hazards of both retinopathy as well as diabetic kidney disease. So in the clinic, in the GP clinic, OP clinic, when you're sitting in the diabetes clinic, all we need to do is use 6 simple variables which are available in every practice. So your age at diagnosis, your BMI, waist, A1C, triglyceride, and HDL. If you are able to do this, we now have an algorithmic calculator which will kind of tell you where your patient is sitting and whom you need to focus on in terms of early aggressive treatment. And that brings precision medicine to the diabetic clinic in India. Thank you very much.
Thank you, Dr. Anjana Madam, for such a wonderful talk. And really, I'm amused by how simple it is to classify, but it was very difficult unless you did it. So just a question, ma'am. You have told that subtype 3, the SID one, can be very easily detected by TG levels and HDL levels and HbA1c. We can do it, and they are the most difficult to tackle also because they have the both features. So any enlightenment on that for the physicians who are attending this?
Yeah, so if you look at it, so you don't have to manually sit and do it every time. So, I mean, I don't expect anyone to sit and see, oh, what is the triglyceride hedge? We have these calculators. So we're trying to get a kind of algorithmic calculator. It's like an app which you can download on your system and keep. And then if you just enter the variables as is, so the lipid profile and the thing, it will calculate the risk and it will tell you. It's called a Diana calculator. We already have it with us, so it should be able to give it out soon. So what it does is it will tell you, so see, in human biology, you can never say someone is in one category versus another category. So it will tell you your risk of having SID is like 70%, 80%. And thus your risk for retinopathy, nephropathy is X. So as a physician, you know that if you're in an insulin deficient, the patient is in an insulin deficient category, like SID or SIRD, then you have, this is someone you're going to tightly control. So that way it helps you. It will never definitely because this is done at a population level. So for an individual, it will give you a kind of estimate of what your
probability estimate, if we are very precise. A probability it will give. Thank you, ma'am. Bitul, sir?
So I think this clustering is very, very important since we are moving from generalized medicine to personalized medicine. So if we identify in the beginning that this patient is going to have this risk factor or this problem afterwards, and we start tackling that, in the very beginning, it is going to reduce the complication rate very drastically.
That's the
So I must congratulate you for bringing up this concept. And I think in future also this concept is going to be propagated more intensely so that we can have complication-free diabetes.
Yes, sir. Yes,
so
sir.
Controlling of diabetes is now going beyond that. We are going to, futuristic medicine through, you can say, predict the complication afterwards.
Yes. Yes,
yeah,
that's the hope. And next stage, we hope that we're trying to link the genes to this. So that work is ongoing now.
Yeah,
so
definitely.
The hope is with a single drop of blood, when patient comes, we can straight away have a gene SNP thing, which will say you are the person who will go in for retinopathy, nephropathy. So for you, tribe control is necessary, etc., etc. So, or which drug response will be, to which genetic code it can be mapped.
So definitely it is very important in India, otherwise very poor country. So those who can afford, so they can go in for personalized medicine. Those who cannot, they can strive to control diabetes at least.
Yes.
Yeah.
So hopefully
Thank
this
you.
will be connected. Thank you.
Thank you, ma'am. Thank you.
Is it okay for me to leave, or are there other questions later on, or?
No, ma'am. Thanks a lot.
No,
this was just a game changer.
No. There will be questions. Dr. Chandali about to go out. That's the reason. There may be questions afterward also.
Okay, I'll wait, sir.
You can stay for some time. It will be great.
Yes, I'll stay. Yeah. Thank you, Meenakshi. Hello, Meenakshi Sundaram, sir.
Good evening. Right.
So please go ahead and introduce next speaker.
Can you put on the slide, Sundaram, sir? Our next speaker is Dr. Meenakshi Sundaram Shanmugavelu. Sir is from Trichy, and sir is chairman of Trichy Diabetes Specialty Center. Sir has done his FRCP from Glasgow and FICP, Indian College of Physician Fellow he is. He served in Tamil Nadu Medical Services, a life member of many associations, a member of EASD, ADA, Diabetes UK and ACP, conjoined overseas faculty University of Newcastle, Australia from 2001 to 2005. He has been a regional faculty for PHFI India. He published articles in various journals and contributed topics to textbook of diabetes mellitus. He presented papers in various forums, participated in phase 3, phase 4 clinical trials and epidemiological studies as a PI, and received Dr. Sam G.P. Moses Oration Award, Economic Times Inspiring Diabetologist of India Award, and Tapicon 2018 Dr. Aluraj Guest Lecture. So he will be talking about a very important topic, setting up of a diabetes care center. Over to you, sir.
Sir, please provide me the option to share my screen. Is it visible?
Yes.
Yes, sir.
Respected chairperson, co-speakers, learned viewers, and listeners of this program, I feel very much happy, honored, and most privileged to have been invited to make a presentation on setting up of a diabetes care center with a particular focus on creating happiness in the diabetes care center. I thank Dr. Bansi Sabu sir and his organizing committee members for the kind invitations. My disclosures, what I'm going to do for another 20 minutes. The contents of my talk line includes interaction, the need for diabetes care centers, steps involved, the role of technology, and of course, summary. So diabetes mellitus is a global public health crisis. It is estimated that more than 463 million people worldwide have diabetes, and this number is projected to reach 578 million by 2030 and 700 million by 2045. India is in the forefront in terms of patient load for diabetes. What's the need for diabetes care centers? Diabetes care is a challenging task, both for the person with the diabetes and the diabetes care provider. Poor management leads to poor patient satisfaction and results in suboptimal outcome. One of the challenges that is the pressure to see huge caseload in limited time. So that results in poor management, poor patient satisfaction, and suboptimal outcome. So it is essential to have a proper setup in terms of infrastructure, staffing, resources, etc. Next is need for diabetes care centers. Sorry. What's the scope for diabetes care centers? So there is always a scope for diabetes center in view of growing magnitude of diabetic patients, low ratio of specialist doctor patients in India, the need for comprehensive diabetes management, non-availability of accredited centers in semi-urban and rural settings. So very important thing, diabetes is a demanding condition, which requires efforts and energy from persons living with this disease as well as their healthcare providers. So our goals or objectives are to provide a service with exceptional benefits to patients with diabetes in terms of prevention, management beyond their expectations, to participate actively in building a healthier community in India, to develop this department into a renowned unit in a hospital that enhances its reputation and prestige, to provide a service at minimal cost, to create a state of recognition, improve the clinical care delivery, become messengers in education for patients with diabetes, most importantly, to achieve maximum patient satisfaction, which is another free marketing gesture. So the queries, the doubts, and concerns that a person living with the diabetes are always limitless in nature and number. We are supposed to make them feel happy whenever we come across patients with the diabetes in our center. So what are the steps involved? Visit established diabetes centers before you have plans in your mind to set up. Seek advice from seniors and peers. Conduct review polls if needed. Review diabetes-related statistics in the locality. Work on the logistics part of setting up a clinic. Try out in a small scale first, if unsure. And stage of establishment. Seek all logistic approvals needed. Plan the facility in a patient-friendly manner. Locate nearby lab and pharmacy facilities if not available within the center. Recruit support team of doctors, paramedical or non-medical staff. And very important thing is popularize the center using routine and social media related announcement. No direct advertising is permitted. Next is lab facilities. Of course, we know the routine laboratory parameters to be assessed. Very important thing is with reference to equipment, technicians, pathologists, and of course, the microbiologist. Next is staffing requirements and resources will vary from one place to another. So diabetic specialist staffing and associated service requirements that include consultant diabetologists, physicians, endocrinologists, duty doctors, specialist nurse, certified dietitians, educators, podiatrists, and next is facility for managing children and adolescent services, pediatric trained staff, specialist staff, pediatric services, services for the management of pregnant women with diabetes, care of the elderly with diabetes, and sometimes some of the centers, they run joint specialty clinic involving specialists in internal medicine, ophthalmologists, cardiologists, neurologists, nephrologists, intensivists. They visit the particular center at a particular time. So they may be on call. Department of Surgery, Plastic Surgery, Vascular Surgery, Department of Radiology and Imaging, Foot Care Services, Dental Services, Counseling for Sexual Disorders, Clinical Psychology Services, of course, physiotherapy and rehabilitation. So what are the miscellaneous aspects? Establish medical record system, review licenses and permits on a regular basis, update knowledge on recent advances for self-help teams, adapt to changing times in view of technology, expand the network in a steady fashion, and kindly put a board providing the facilities offered in a particular diabetic department, and also provide a space for the comprehensive services. Equipments to be installed like X-ray machine, ECG, ultrasound, echo, vascular Doppler, and of course, foot services. Next is what are the responsibility of a consultant physician with a specialist training in diabetes. They normally look at the outpatient, inpatient services, consultant advice to hospital colleagues, training, supervision, and support of medical and other staff, medical advice to the managers of diabetes services in the hospital, and leadership of strategic planning to ensure equity of service access. Very important thing is high standard of care for all people with the diabetes and professional support to the group of patients and continuity of care. Next is the responsibility of duty of a duty doctor. Other medical staff will be required to support the consultants in undertaking the above tasks. They may include doctors, associate specialists, hospital practitioners, and clinical assistants. Next is the responsibility of specialist nurse in diabetes. That is, they have specialist training and specialist nursing responsibility. They should undertake the initial education, advice to patients with the diabetes and their carers and those at risk of developing diabetes. That is equally important. Continuing education, advice, and support to patients and their carers, initiation and adjustment of oral hypoglycemic drugs or insulin treatment, education, advice, and support for general practice diabetes care teams. They could include involvement in the setting up of accredited courses for other professionals also. Next is the role of dietitians, either registered or specialist diabetes dietitians. They provide dietetic advice to all patients with the newly diagnosed diabetes, their carers, and those at risk of developing diabetes. Continuing dietetic advice and education to patients with the diabetes and their carers, education, advice, and outreach support for primary care diabetes services, and education and advice to other healthcare professionals involved in diabetes care. Next is what is the role of diabetic educators. In fact, they are healthcare professionals. They focus on helping people with the diabetes to understand the disease and learn how to adjust the lifestyle, behavior, so that they can develop diabetes self-management skills. They should also provide the following, namely, they develop goals and objectives for diabetes program. They review, select, or develop educational and counseling materials on diabetes self-care to be used for educational purposes. They provide education to clients and family members regarding self-care, attend workshops and seminars for education and training purposes. Here a podist or podiatrist responsibility, education on foot care to all new patients with diabetes and their carers, focusing on prevention. Ongoing education of patients with diabetes and their carers. Education, advice, and license and outreach support to primary care diabetes teams. A rapid and open access for treatment and advice to patients with foot problems, and especially ulcers, management of foot ulcers, an essential role in diabetes foot care services. Next is children adolescent services. Very important thing is a consultant pediatrician with a specialist training in diabetes care is also essential for the initial assessment, treatment, support, and follow-up of all children with diabetes and their carers. And these pediatric services should always be supported by pediatric trained specialist diabetes nursing, dietetic, and psychology services, both for inpatient and outpatient services, and should be closely linked to the adult diabetes specialist services. Next is care of the elderly with the diabetes. So if you look into the incidence and prevalence of diabetes, it increases with age, and there are a large number of elderly people with the diabetes in all locations. Many people with it will always have combined problems. Such people may benefit from the multidisciplinary skills of both diabetes and care of the elderly specialist team. We need to give considered where possible to the presence and appointment of a consultant in care of the elderly with specialist training in diabetes. Next is services for the management of pregnant women with the diabetes. So a consultant obstetrician with a special interest in the management of pregnant women with the diabetes is always recommended. And pregnant women with the diabetes should be managed jointly by members of the hospital diabetes care team and a specialist diabetes obstetric team, which should include a nurse, midwife, and obstetrician. The training and provision of diabetes specialist midwife should be encouraged. And we need to provide pre-conception care, and also specialist contraceptive advice should be made available for women with the diabetes in the childbearing years of life. And that should be a formal screening and management guideline for gestational diabetes. Next is ophthalmic services. There should be a program to screen eyes of all patients with the diabetes. And there should be agreed guidelines for referring patients to ophthalmology department. And there should be a rapid access to effective ophthalmic treatment. Next is food care services. The special problems require facilities and resources to include a named diabetic food care team and food clinic available to both for the hospital as well as for the community, and open access for chiropody for people with food problems, and access to an orthotist for footwear advice, and also providing the therapeutic footwear to the individual. Next is access to named surgical and radiological vascular services and services, especially rehabilitation to support people requiring amputation. Of course, cardiovascular services, that is hospital screening, treatment, and referral program for the detection and management of cardiovascular risk factors in patients with diabetes, and access to named cardiology and vascular services, and of course, joint multidisciplinary clinics are recommended to save duplication of visits. Next is nephro and urology services, that is agreed hospital screening, treatment, and referral programs for patients with established nephropathy, and agreed referral policy to a named specialist renal unit and renal support team for people with end-stage renal disease. Again, joint multidisciplinary clinics are recommended. Next is counseling for sexual dysfunction. Agreed guidelines, facilities, and resources should be available for the assessment and provision of treatment for erectile dysfunction. Next is clinical psychology services. People with the diabetes and their parents should have access to a clinical psychologist. Such a person should be an integral part of the diabetes team. Next is regarding the policy plan. And of course, this is a brief account of the procedure that will be carried out in the diabetes center. Of course, this is subjected to modification to suit the services offered at each diabetes department. And the procedure, center should have a clear set procedure in the management of patients. New patients are received at the reception where they are issued with a diabetic file that contains so many cards, the prescription papers, the monitoring chart, the request form to eye department, the anti-smoking clinic, alcohol de-addiction room, information message to diabetics, program for lectures in the center, instruction sheet to the dietitian, diabetic educator, food services. Then the patient is referred to doctor on duty, and the duty doctor will take down the detailed history from the patient with a specific emphasis on diabetes and its complications. They then refer to the diabetes specialist nurse. They elicit vital signs, including blood pressure, pulse temperature, body mass index, waist circumference, fat percentage. They take ECG and they direct the patient to the lab. And after the required data is obtained and placed on file, the patient is referred to consultant for consultation, evaluation, management. So patient is made to feel ease, reading the information data on the file to gain insight into the patient's concern, listening to the history carefully and determining the relevant part of the history. A thorough physical examination, including the search and detection of target organ damage. And we need to give the requisition for the investigative procedure, which will assist in the evaluation of its status and plan the basic treatment where possible at this stage. Then we can refer our patients to dietary advice, diet planning in accordance with the individual dietary likes, and modifying the diet based on the type of diabetes, BMI, and activity, etc. an instruct diabetic educator with specific emphasis on the individual needs of the patient, which include informing and educating the patient about diabetes and its complications, exercise plans relevant to the patient's age, level of basal activity, taking into consideration the cardiovascular pulmonary status, body mass index, waist circumference, physical and musculoskeletal status, and the degree of compliance and tolerance, and educating the patient on oral hypoglycemic agents, when to use them, when to stop them, how they work, the risk of hypo, adverse effects, and drug interactions, how to use the glucose monitoring chart. Next is with reference to insulin therapy, educating the patient on what insulin is and how it works, action, duration of the prescribed ones, how and where to inject. The educator may do a demonstration for patient. And how to use the glucose monitoring chart for insulin therapy, how to recognize the hypo and the management and how to avoid it in the future, how to synchronize diet and exercise with insulin therapy, how to adjust dosage at a later stage. Next is advice on proper care of the feet and therapeutics as well. So the ideal diabetes care team I have gone through, and hierarchy of the diabetes care team starting from the patient down to the psychologist, of course, podiatrist, pharmacist, right? So the goals of diabetes care center includes organized diabetes care, including diagnostic facilities, prevention and management of complications, lifestyle advice, diabetes education, individualist treatment. Of course, the role of technology. Developing a new model of diabetes care that is essential to accommodate the overwhelming number of patients with diabetes, and the recent technological evolutions that focus on improving healthcare efficiency are promising. Of course, we have telehealth, remote operation of healthcare through telecommunication. This enables long-distance clinical care, healthcare, and professional health-related education electronically. We have the telemedicine, the remote practice of medicine between a physician and patient. We have the e-health, mobile health, using the mobile technology to deliver real-time health and metabolic information. And these are the benefits of telehealth in diabetes, with reference to improvement in diabetes care, help in preventing diabetes complications, save patients time and cost by eliminating the need for traveling long distance, and increasing the frequency of visit improves clinical outcomes based on the data with reference to glycemic parameters, LDL, as well as BP goal over a period of 1 to 2 weeks versus 3 to 6 months. Next is challenges with the telehealth. We know that include problems with the payment of fees, and of course, high-speed broadband connection does not currently reach numerous rural areas. And creating a virtual diabetes care center, Jocelyn Horn, is an innovative model of virtual diabetes clinic. It is a team approach that includes so many caregivers and community members. And of course, this can be tried out in Indian setting with the limited sources. And the typical benefits of telehealth through Jocelyn's Home, it involves short visits, frequent visits, and low over cost. In short, diabetes care centers are the need of the day owing to the growing diabetic population and the current unmet needs. These centers should be self-sustained, well-equipped to cater to all clinical needs of diabetic patients in India. A hardworking and cohesive team of medical, paramedical, and non-medical personnel is essential. There is a need to adapt to latest advances like technology that is required to sustain on the long term. My beloved doctor friends, please remain safe, take care, stay healthy, protected, and connected in the days to come. I'll stop sharing my screen. I once again thank the organizing committee members for the kind invitation.
So thank you, sir. I must congratulate Dr. Bansi Saboo as well as the scientific committee for this session, because we started from the history of diabetes from ancient to modern, coming on to the personalized medicine with clusters, and ending up with setting up of diabetes centers, which is the need of the hour. So basically, diabetes need to be focused as a primary disease, which is causing so many complications. And if we proceed in this way, that we give personalized medicine through personalized diabetic care centers, I think we will be able to control the complications, reduce the complications, as well as control diabetes. So I must congratulate the scientific committee for innovative, a complete session, which is going to give us the roadmap for next 3 days. Dr. Bharat, please.
Thank you, Meenakshi Sundaram sir, for beautifully telling us how to develop a state-of-the-art diabetes care setup. But just for the audience, what are the basic minimum with which a diabetic care center can start? A basic minimum.
Basic means a physician or a diabetologist or endocrinologist with a dietitian and also a caregiver, a diabetic educator with minimum laboratory facilities as well as foot evaluation, that is neurovascular status evaluation.
Thank you, sir.
So we can invite few questions if there is time. So if there are no questions, I think we should end the session with a congratulatory note for Dr. Bansi Sabu and his entire team, as well as the scientific committee for this excellently devised, session. Thank you very much.
Thank you, sir.
Thank you, speakers, organizing committee, for this wonderful, wonderful event. Thanks a lot.
Thank you. Thank you, sir.
Thank you, ma'am. Thanks a lot.
Thank you.
Thank you, Dr. Jana. Thank you.
Yeah.
Bye.
Thank you, Yagnik sir.
Everyone, thank you, chairperson, and thank you, speakers. Now we can move over next session. And I would like to over the session to Dr. Rupam.
Yes. Good evening, all. Myself, Dr. Rupam Chaudhary from Guwahati. A warm welcome to all present out here in Diabetes India 2021. And for the next session, we have the state of the art lecture. And it is my privilege to invite Dr. V.N. Shah, consultant diabetologist. He's from Ahmedabad. And Dr. Deepak Yagnik, diabetologist from Kanpur, to chair the session.
Thank you, Dr. Rupam Chaudhary. The Shah is not probably here. May I have a first slide for speaker? Introduction slide.
So now you can start, sir.
Thank you, Dr. Bansi, for inviting us as a chairperson in this prestigious conference. May I have a first speaker's introduction slide? From RX event, please. Yeah, thank you. Yeah. Our first speaker for this session is Dr. C.S. Yagnik. Although the name itself is a pro-explanatory, and I am privileged to introduce another Yagnik by a Yagnik. Professor Yagnik has focused his research on high susceptibility of Indian to the diabetes. He is well known for his description of a thin fat Indian. He investigates intervention program of the diabetes and maternal undernutrition in pregnancy and diabetes. He is a president of Sneha India, Society for Natal Effect on Health in Adults, and a treasurer to International DOHAD Society. He has won many international awards and is ranked in top 2% of the world scientists in the recent Stanford University list. Sir, we have proud on you that you are among us as a endocrinologist and diabetologist in India. And now I invite Dr. Yagnik to deliver his talk about the experiences through his Pune center.
Thank you, Deepak. If they could give me the sharing rights, I will share my slides. Okay, events,
yes, sir, now you can share your slide.
Let me share. Okay, good afternoon, everybody. And thank you, Chairperson, Dr. Deepak, and the organizers for the opportunity to speak in this meeting. I'm going to tell you a story from the Pune Maternal Nutrition Study, which many of you would know I set up 30 years ago. And now the participants in the birth cohort have grown up, and many of them have now developed pre-diabetes. So we are able to trace the life course history. My department has a logo of mother and baby because that's what our focus of research is. And the modern Ganesh was changed from his original habits to clicking the mice rather than traveling on the back of this mouse. And that has been the rapid transition in the India over last 50 years or so. And this is my institute, the KEM Hospital and Research Center. So the natural history of diabetes, as we depict it, it starts with a normal glucose tolerance state, then progresses to pre-diabetes, and then finally it crosses into the cut points, which we define as diabetes. Pre-diabetes has attracted attention mainly because the participants in the diabetes prevention trials are chosen to have pre-diabetes so that we can interact with them, we can intervene and try and prevent diabetes. But I'm going to tell you the story that starts much before that time, even before probably NGT, if that's possible, and then take you through the life course of a participant in the Pune studies. The typical dogma in a textbook for type 2 diabetes is that there is a genetic inheritance, which we say is non-modifiable, especially because it's polygenic for type 2 diabetes. Because we say the susceptibility is non-modifiable, we have concentrated on the precipitating factors, and which largely include aging and obesity, contributed by changes in diet, physical inactivity, and stress. And therefore, the participants in the diabetes prevention trials are usually in 50s with a body mass index in obese range and with an impairment of the glucose tolerance. And I'll try and convince you that this is too late and we are going to do too little for them to benefit from that. The challenge to this dogma came from David Barker in 1990s when he wrote his thrifty phenotype hypothesis. I have to tell you that I suggested him the name thrifty phenotype when he first met me in 1991 in my office, trying to convince me to join him in his research. And what he showed me was this remarkable paper in British Medical Journal, where he showed that lower birth weight was associated with higher incidence of glucose intolerance and metabolic syndrome in a cohort which he had studied in the UK. Because India is world's capital for low birth weight babies, he was traveling in India to see if a diabetologist would be able to join him in this research. And after this paper, he wrote this hypothesis where he said type 2 diabetes is the outcome of the fetus and the early infant having to be nutritionally thrifty. And I have joined him since then and done a lot of research with him. Later on, from FOAD, which is what David Barker said, fetal origins of adult disease, the idea changed to developmental origins of health and disease, to incorporate the idea that it's an ongoing process starting around the time of conception, depending on maternal factors and the intrauterine environment, heavily driven by epigenetic events rather than the genetic sort of inheritance, reflecting in fetal growth and development, manifest in the birth phenotype, and then continuing to go through the childhood, puberty, and adult age, ending up with risk factors, morbidity, or mortality. So DOHAD has brought us out of the genetics plus the adult lifestyle conundrum. And Pune Maternal Nutrition Study was set up in 1993 in 6 villages near Pune, exactly to answer these questions. The two primary aims were to find out the determinants of fetal growth in Indian villages and to study the life course evolution of phenotypes, especially what we call diabesity, that was combination of diabetes and adiposity. We studied over 2,500 women who were married but not pregnant. 814 of them became pregnant, who were intensively studied 3 times in pregnancy. They delivered babies whom we measured again quite elaborately at birth, and then measured them every 6 months for 18 years, and then subsequently every year for their growth. Every 6 years, we analyze or call them to the department for an overnight stay and study their size, body composition, nutritional intake, physical activity, glucose tolerance test, cardiovascular risk factors, body composition, cognition, a lot of things. The last follow-up started in 2019 at 24 years of age, but in February 20, we had to stop after we had studied 270 families out of possible 700 because of the COVID pandemic. We will pick up when the time allows us. And we have created an extensive biobank over the last 30 years with more than 300,000 tubes in our freezers from various biological fluids. At 18 years of age, that's what we are going to concentrate today. These children had a very substantial prevalence of prediabetes. Almost 1 out of 3 were pre-diabetic, boys more than the girls. 27% of boys had impaired fasting glucose. 10% of boys had impaired glucose tolerance test, while in girls, about 10% had IFG and IGT, and 2 had become diabetic, but 1 of them was MODY. Just to show you that there were considerable nutritional deficiencies in this population shown here for B12. We are not going to talk about that today, but almost 50 to 60% of the population was B12 deficient. In short, about 40% of males and 20% of females had some glucose level which could classify them into ADA criteria of prediabetes. And how did they differ from those who were normal glucose tolerant? To begin with, men were shorter by almost 2 centimeters. Females had almost a similar height. Body mass index on higher side, but not significantly. Remember, the mean body mass index only 19. And almost 45% of this population was still underweight. That means body mass index of less than 18.5. 8.6% of high glucose, that's pre-diabetic, had overweight obesity, 5% in the normal group. This is by the international criteria of BMI 25 and above. When we measured body fat by DEXA, males with impaired glucose tolerance had higher body fat, so they were adipose, but not girls. though girls have much more body fat than boys as a physiological phenomenon. And triglycerides were borderline high in the high glucose children. Then we decided to look at the two physiological measurements of insulin sensitivity and insulin secretion, which we know contributes to the glucose intolerance. And I look upon this as a capacity load imbalance. Load comes from insulin resistance, and capacity of the beta cells to respond to that determine your glucose tolerance. And we had the opportunity to study their childhood measurements. And this is because of the birth cohort prospective measurements. A Danish philosopher had said this long time ago. He said, life can only be understood backwards. And this is how it looked. Those who were pre-diabetic at 18 years of age naturally had higher glucose because that's how we have classified them. Green ones are the normal glucose tolerant. But what is surprising is that those who are glucose intolerant at 18 years had higher glucose at 12 years and higher glucose at 6 years of age compared to those who remained normal glucose tolerant at 18 years of age. So what you see at 18 years is just a reflection of the impaired glucose metabolism, which is detectable as early as 6 years. That was the first time we obtained the blood in this cohort. For insulin concentrations in the fasting state, the insulin concentrations in glucose intolerant people at the time of 18-year glucose tolerance test were higher, as has been shown in many other cohorts, but we will discuss this, what it means. However, their insulin concentrations in fasting state at 12 and 6 years were no different than the normal glucose tolerant people. So obviously, glucose and insulin cannot be interpreted alone because both are very interdependent. And that's why we decided to use HOMA model. I trained in Oxford with this group 40 years ago, and we are very fond of using this model. The model is developed in about 25 young, healthy Englishmen. Therefore, their values are taken as normal or 100%. And what figures we will show for our cohort or any papers which show you are a relative comparison with these young, healthy Englishmen. And nowadays, it's very easy to go to the site of the DTU, the Diabetes Trials Unit in the UK, use the HOMA calculator and calculate the values. So this is what we did. We calculated HOMA S, that is HOMA sensitivity. This is the inverse of HOMA resistance, and HOMA beta, which is the beta cell function. And what we see is that those who were impaired glucose tolerant or pre-diabetic at 18 years had a lower insulin sensitivity at 18 years, especially, at 18, not at 12 years and not at 6 years. So they showed impaired sensitivity at the time of diagnosis of pre-diabetes. On the other hand, the beta cell function was comparable even at 18 years and of course at 12 and 6 years. This could be slightly confusing. There is a progressive change from early age to 18 years, but no distinction between the two groups. And this change from early to late years is very interesting. You can see at 6 years, the Indian children had almost 300% sensitivity. That means they are 3 times more sensitive than the young 25-year-old Englishman. By 12 years, they had come down to about 170%. And by 18 years, they were about 80% of the sensitivity of the Englishman. So they were more resistant than the similar aged Englishman. While the beta cell function at 6 years was about 60% of the average English, it increased to 80% and over 100% by 18 years, probably to compensate for this decreasing insulin sensitivity. So it's an important lesson that HOMA-S and HOMA-beta change progressively and concomitantly during the life course. And therefore, we have to put these into relation to each other. And this was actually sort of popularized by Bergman in about late 90s and early 2000 by what he called the hyperbolic correction, where you plot insulin sensitivity against insulin secretion and see that there is a hyperbolic curve. And this actually led to description of what we call disposition index, which is a multiplication of sensitivity and secretion. And this remains constant over a period of time, as we will see. So this is the plot of the HOMA sensitivity against HOMA beta in this population at 6 years, 12 years, and 18 years. And what it shows is that at 6 years, as I told you, the children are much more sensitive and with a relatively lower beta cell function, because that is what is required to keep the glucose in the normal range. By 12 years, their sensitivity is shifting to the left and beta cells are compensating by increasing their function. But by 18 years, the sensitivity has contracted considerably and the beta cell function had to increase proportionately. And the green group is the normal glucose tolerant. Red is the pre-diabetes, and you can see a clear separation. The beta cells in those who are pre-diabetic are not able to compensate for the increased insulin resistance. And this is again shown as a log-log plot that from 6 to 12 years, there is a progressive change in insulin sensitivity, that is fall, rise in beta, but at each point, if you look at the median value, those who were diagnosed glucose intolerant or pre-diabetic at 18 years are tracking on a lower line. That means the abnormal response of the beta cell to the prevailing insulin was as early as 6. At 18 years, again, as I told you, we could find, yes, difference in HOMA sensitivity, not by the HOMA beta measurement, but disposition index was already low, and that was what was contributing. So failure of beta cell compensation to the changing insulin resistance or the sensitivity is the major contribution to the developing glucose intolerance. Because we have so much other data, we are able to talk about other things. Were these children born low birth weight? No, but they were born shorter at birth. So both the females and males had lower length at birth. The girls remained lower height throughout their 18 years. Boys also a little bit on the lower side of the reference range. Weight-wise, girls have remained low weight and boys near normal weight, but progressively produce or increase weight during puberty so that their BMI is higher than the normal glucose tolerance during the pubertal years. So this is a demonstration that if you are pre-diabetic at 18 years, you were born lower length or you were born shorter or stunted, and that was the manifestation of intrauterine growth restriction, which David Barker had described. What about the glucose at 6 and 12 years? I told you that they had high glucose. This we have modeled. And what we show here is that glucose level at 6 years was strongly related to glucose at 18 years. And if you look at the lowest and the highest quintile, that is the fifths of glucose distribution, at 6 years, the highest quintile glucose at 6 years increased the risk of pre-diabetes by 3 times at 18 years. And for 12 years, if glucose was high, it increased the risk 6 times. And the ROC shows that the area under the curve was about 0.7. So then we looked at other factors which might be related to prediabetes at the 18 years. And what we find is female sex has a lower risk, which I had shown you before, 20% against 40%. Mother, ever overweight. Today we are able to, or today we think that overweight obesity in the mother is driving the epidemic. But in this village population, lack of obesity in the mother was a driving factor for glucose intolerance in the child. Mother's glucose, though they were normal glucose tolerant in pregnancy, within that normal value, higher glucose predicted higher glucose in the baby. So evidence for intrauterine programming by maternal glycemia. Paternal glucose intolerance increased risk only in the female child. And as I said, lower birth length and lower head circumference were higher glucose. In addition, we have shown you 6 and 12-year glucose and higher body fat in males. So this is a complete life course demonstration that what factors program the risk of high glucose in the child right from before the time of conception, during pregnancy, and through the childhood and puberty. So what we are now saying is, unlike the conventional model, we are saying that diabetes prevention trials should start very early in life, especially by reducing the risk factors in the young girls so that they produce children which are less likely to be diabetic in future. And therefore, this has become a famous saying now, it all begins before the beginning. So to summarize, the implications of our study are that type 2 diabetes has an intergenerational life course evolution. Metabolic abnormalities are evident very early in childhood. There is a progressive accumulation of risk. There is an imbalance in insulin sensitivity and secretion progression during childhood and puberty. We are able to predict future risk through parental glucose tolerance, birth length and head circumference, and fasting plasma glucose in the child. This has implications for public health policy to look into improving the fetal growth, which of course for more than one reasons is true. Childhood screening for glucose so that you can do high risk targeted intervention, and lifestyle advice for the whole population. Now, it would be interesting to see whether these young people in future develop diabetes at young age and whether our findings would contribute to treatment strategies in them. Though we will have to wait few years in the cohort to achieve that, we have done the clusters analysis in 3 places in India. This paper is now accepted for publication in Diabetologia, and I'm going to speak about this day after tomorrow afternoon to talk about subgroups or clusters in Indian clinics. 3 clinics contributed data to this. My own clinic with nearly 2,000 patients. Dr. Banshi Sabu from Ahmedabad contributed about 250 patients who were diagnosed before 45 years of age, and Dr. Anupam Datta and Sanjeev Kakati from Dibrugarh. And interestingly, what we find is severely insulin deficient diabetes is the predominant group in our young type 2 diabetes patients in the clinic, like what we showed cohort Pune maternal study. It was the failure of beta cell to compensate. Ultimately, a time comes when load becomes too much and they crash. This was true in Ahmedabad, and this was very much true in Assam, where almost 2 out of 3 patients in the Assam Medical College clinic were severely insulin deficient. So if you are interested in this, please come and join me in a couple of days' time to listen more about these clusters. Finally, thank you to the participants, my department, and a series of collaborators from India and abroad who have contributed to this work. Thank you, Chairman. Thank you very much.
Thank you, Dr. Yagnik, for nice presentation and a excellent insight about the journey of diabetes, how we can prevent it from being diabetic of a younger age, giving a good insight about it, that it begins before the beginning. It's very true. Dr. Rahul, should we have a question answer before the next session or at the end of the session? Probably he's mute. Yeah. And Dr. Yagnik, may I have one question only? With this study, how we can interpret that, how we have to prevent diabetes, or how we have to prepare the would-be mother to prevention of diabetes in our society? What's your message about it?
It's a two-pronged intervention to improve the nutrition of the mother so that she produces a healthy weight, healthy grown baby, for which we have to improve the balance of the nutrition. At the same time, the mothers in India who are underweight and undernourished today themselves had undernourishment when they were growing in the womb. And therefore, there is an increasing prevalence of gestational diabetes. So the new generation babies are facing a double whammy. On one hand, ongoing undernutrition because of poverty and intergenerational undernutrition. And the new block on the kid is gestational diabetes. So we have to take care of these two. I have proposed this as a hypothesis called dual teratogenesis, that low undernutrition and overnutrition of glucose for the baby is the worst combination. And that's probably the reason for explosion of diabetes epidemic in India. So we have to take care of undernutrition as well as fetal overnutrition, so maternal gestational diabetes. That would be my advice. And this is a very substantial undertaking at Public Health. So we will continue to discuss this in this meeting, but that's the bottom line. Thank you for the question.
Thank you, Dr. Rupam, may I have a second slide for the introduction of our second international speaker? Yeah, thank you. So today our second speaker is an international speaker, Dr. Michael Hermans from Belgium. He is a senior consultant at St. Louis Academic Hospital in Brussels. He is a surgeon at Jane Price from the Association of Belgia du Diabeta. He is a visiting fellow to the Diabetes Research Laboratory, Oxford University, and he is going to speak on SARS-CoV-2 infection compared to the uninfected proportion. And this is probably the hottest topic of the day, as well as it is really required in this epidemic time to India. So I request Dr. Michael Hermans to deliver his talk. Please unshare yourself, and then so Dr. Michael can share his slides.
Yeah, thank you very much. Thank you for the kind invitation from Banshi Saboo. And I hope everybody can see my slides.
Sure.
Excellent. So I need to put it in presentation. Okay, can you all see my slides?
Visible.
Okay, thank you. So the title of my topic are which are the phenotypic features of diabetic patients just prior to getting infected. So I will not discuss about what decides the severity, or I will not discuss a lot about that. But what I did was just to analyze among my own patients the phenotype that they had just before getting infected. And I compared those infected patients to those who did not get an infection. As you know, Belgium was one of the worst hit countries in the world, given for its population. We had more than 25,000 deaths for a population which is about that of a large city in India. So if you extrapolate the number of deaths that we had in Belgium, that would amount to more than 3 million deaths in India. So the three waves were very lethal. And altogether, I was able to analyze slightly over 800 patients for whom I could definitely confirm that they had been infected or not. So it was not only self-reported, but also serologically proven. And all the patients who reported being negative were confirmed negative throughout with serological confirmation. So among those 800 patients, we got an infection incidence of 14%, which is a small cohort of slightly over 100 patients. And I compare them to a very well characterized cohort of patients, among them slightly below 700 were uninfected. So I will just show you the univariate analysis that I did. We haven't yet published anything because we want, of course, to increase the numbers. So just comparing those who got infected to those who did not, there was immediately a difference in age. On average, in a mix of type 1 and type 2 diabetic patients, the average age of those who got infected was 4 years younger, at 58. The proportion of patients was not different, and also the proportion of type 2 versus type 1 was similar across infected and uninfected, as was the male number of patients and the gender ratio. What was very different was the underrepresentation of Belgian citizens among infected at only 45% versus 60% in uninfected. And that was caused to an overrepresentation of ethnic minorities in Belgium. We mostly have patients from North Africa, Sub-Saharan Africa, and Turkey, and they were all overrepresented in those patients who got infected. There was no difference in diabetes duration among infected and uninfected patients. On the other hand, the BMI was significantly and markedly higher among those who were infected, more than 1 unit BMI. And you will see throughout my slides that this is something that comes throughout the study. So having a higher BMI prior to getting infected increases the odds of getting infected. The prevalence of hypertension was high in both groups, and there was no difference in HbA1c among the two groups. Now, looking at their treatments, there was a significant difference in use of lipid-lowering drugs. The infected patients were less often using lipid-lowering drugs, and this was mostly due to a lesser use of statins. On the other hand, patients who got infected reported much more often of statin intolerance, what we call statin-associated muscle symptoms. And this was checked systematically in all patients, and this was highly significant, even for such a small number of patients. There was no difference in ezetimibe use, and also no difference in their lipid profile just prior to getting infected, with an average LDL of 75 milligram per deciliter. There was a big difference in C-reactive protein, which was significantly higher among those who got infected. And the difference was not only ascribed to the higher BMI. Even after correcting for BMI, the CRP was higher before getting infected. Regarding vitamin D, the status was not satisfactory. It was just close to the lower limit of normal, but it was not different across the two groups. There was also no difference whatsoever in this mixed group of type 2 and type 1 diabetics regarding their prevalent vascular complications of micro and macroangiopathy just prior to infection. Then the next step that we did, even though the numbers are not very high, we split the analysis according to the timing of birth of those patients. Could just be a chance finding, but those patients who were born in spring got more often infected. This is a very small number of patients, so it needs to be confirmed or refuted in a larger cohort. Now, if we focus on the subgroup, the dominant subgroup of type 2 diabetics who got infected versus those who did not, there was this time no significant difference in age. There was a 2 years average difference, which did not reach significance. Again, there was no difference in gender distribution. But again, as in the whole cohort, there was a major difference in BMI, more than 1 unit higher in patients who got infected. When looking at what underlies that increased BMI is definitely the fat mass, which in absolute terms was 3 kilograms higher on average. Their insulin sensitivity measured by HOMA, all those patients had their insulin sensitivity measured previously, was 50% versus 55%. There was no difference in insulin sensitivity. And their HbA1c was also similar, 7.7%. The prevalence of metabolic syndrome was also similar, as was the prevalence of fatty liver. This is hepatic steatosis measured by echography. As in the whole cohort, C-reactive protein was significantly higher prior to the infection. Looking at drug use, there was no difference in RAS blockers between the two groups. But again, we found a lesser use of lipid-lowering drugs, mostly statins. And when we look at the different types of statin, there was a non-significant higher use of atorvastatin among the infected and a non-significant higher use of rosuvastatin among the uninfected. Translated into atorvastatin equivalent dose, it was similar for the two groups, as was the use of high-intensity statins. We found again a very high prevalence of self-reported muscle intolerance to statins. And to finish with lipid-lowering drugs, there was no difference in fibrate use, but there was a lower use of ezetimibe in the group who got infected. Again, looking at their birth dates, it was found even in that small group that those born in springs were overrepresented in the infected patients, but that needs, of course, to be confirmed in larger cohorts. When looking at the small subgroup who had type 1 diabetes and who got infected versus uninfected, there was a big difference in age, with the younger average age of infected patients. That fits very well with what we know about the transmission of the disease. Again, no difference in sex ratio, nor in diabetes duration, nor in HbA1c. As in type 2 diabetics, their high sensitivity CRP was higher just prior to infection, whereas their vitamin D level was not different. There was a underrepresentation of patients with autoimmune thyroiditis in those who got infected, but remember, it's a very small cohort. The BMI was not significantly different, and regarding vascular complications, there was a lesser prevalence of macroangiopathy, which could be accounted for by the big difference in age, on average a 6-year younger cohort. Then I decided, despite it was a very small number, to compare those who got a severe COVID course versus those who did not. And we found, of course, what we expected to find. They were, on average, older by an average of 15 years. There was no difference in gender distribution. There was, of course, an overrepresentation of type 2 diabetics, likely due to the fact that older people tend to have more severe courses of COVID. Diabetes duration was not different, but be careful, this is a mix of type 1 and type 2. Type 1s are overrepresented in the non-severe forms, whereas type 2 are overrepresented in the severe group. The BMI was also different and likely accounted for both the severe COVID and was probably ascribed to the overrepresentation of type 2 diabetics. Given to waist circumference, there was an excess waist circumference of 8 centimeters, and their fat mass was on average higher by an absolute amount of 6 kilograms on average, which is huge, of course. There was an overrepresentation of metabolic syndrome in the group who did a severe COVID, whereas HbA1c was not different, nor was the level of vitamin D prior to infection. Now, contrary to type 1 diabetics, there was an overrepresentation of autoimmune thyroiditis in the group who got severe infection. Regarding vascular complications, prior to infections, there was no difference between the two groups for those who got infected. Now we looked a bit more carefully into statin use because there was that odd imbalance between atorva versus rosuvastatin. And despite an exactly identical use of statins between severe and non-severe, those using atorvastatin were overrepresented and significantly among the severe COVID patients, whereas those having been treated with rosuvastatin prior to infection with or without ezetimibe were overrepresented in those patients who did not develop a severe COVID. And this despite the atorvastatin equivalent dose being not different between the two groups, nor for the LDL cholesterol just prior to infection. Then I looked at the blood groups. As you know, there's been a lot of reports of some blood groups affording protection or higher odds of getting infected or getting a worse course of the condition. What we found is that among those patients who had severe COVID, there was an underrepresentation of the B plus group, and there was a massively overrepresentation of the very rare AB plus group, which is usually infrequent, and it was extremely highly prevalent in those who got infection. The same was, of course, true when you did not consider the rhesus groups. So, as a summary of this preliminary analysis, if you look at both type 1 and type 2 diabetics together, those who got infected were on average younger. They were less likely to be Belgians and more likely to be of ethnic minorities. They had a higher BMI prior to infections, a lesser use of lipid-lowering drugs, among those a lesser use of statins. They complained more often of muscle intolerance to statin. They had a higher CRP, and this was found throughout all subgroups, a higher CRP before being infected, and that odd finding, which could be a chance finding of being more often born in spring. When you look at the separate types of diabetes, most of the difference in the combined group were driven by the type 2 diabetics, who represented 2/3 of the patients. And looking at severe versus non-severe patients, those who developed severe forms were, of course, older, more obese, more fat. That was expected, but what was less expected was that the use of statins prior to infections was mostly atorvastatin and less often rosuvastatin or ezetimibe, and there was a big imbalance of blood group distribution among those who had severe versus non-severe COVID. Thank you very much for inviting me to talk to this talk with those preliminary results. Thank you.
Thank you, Dr. Mikkel, for an excellent presentation and an excellent observations for this SARS-CoV-2 infection people before infection and after infection, and with the comparison of people who are taking atorvastatin, rosuvastatin, or ezetimibe, as well as the comparison in between the different blood groups with the severe and non-severe infections with the BMI. That's giving us some insight that if the people having lower BMI with no fat mass may be infected, but with the low of severity. And the people who are using statins should be very much cautious about the SARS-CoV-2 infections. And do you have any idea about how this SARS-CoV-2 infection will give rise to new onset of diabetes in your provinces?
Well, I only see type 2 and type 1 diabetics, so I don't have normal patients. Of course, during the cytokine storm, there could be some new onset or so-called new onset type 1 diabetics becoming symptomatic because they had a massive immune response that could trigger type 1 diabetes in predisposed individuals, although I would suspect that they probably had silent pre-type 1 diabetes ongoing before getting admitted to the severe COVID. For people with pre-diabetes, probably they will lose a lot of weight during the COVID condition if it is a severe one, with a loss of muscle mass, of course, and it does not. It's not sure that they will regain that muscle mass once they recover, and they will also have, for some patients with the long COVID post-infection, and also those who were treated with corticoids during the course, could have secondary types of diabetes, at least for the few weeks or months. But I don't see those types of patients personally.
Thank you so much. Thank you, Dr. Michael. Dr. Rupam, may I have the introduction slide of Dr. Anant Nigam? Yeah, thank you. Now, our last speaker of the session is Dr. Anant Nigam, none other than a personality who have started this Diabetes India as a founder member. The director of a Nigam Diabetes Center, Jaipur, fellow of a Royal College of Physicians. His career in diabetes span over 36 years when he set up amongst the India's foremost diabetes center, delivered invited lectures at IDF 2011, invited chair sessions in IDF in 2011-13 diabetes technology meeting in the Maryland, USA, is awarded with several orations, including RSSDI 2010 and Northeast Diabetes Society oration, Professor N. Bau oration, and etc. More and more orations he has with his name. Founding member of World Foundation of the Prevention of Diabetes, Atlanta, on the various committee of the Indian Council of Medical Research for the evaluation of projects, studies, creating consensus guidelines. He has several publications in index national and international journals and has contributed chapter in a textbook also. He is on the editorial board of a diabetes and metabolic syndrome, clinical research and review. Also peer reviewer for the several journals, including the Journal of Diabetes, Science and Technology. He presented papers nationally and internationally in conferences, including the ADA. He has been a chair and organizing committee for National RSDI 2003 and Diabetes India International Conference 2005. Welcome, Dr. Anant Nigam, and he is going to speak on diabesity. Diabesity means diabetes plus obesity, and this has now become an epidemic-like situation in India, that diabetes become diabesity. Dr. Anant Nigam, please.
Thank you very much, Dr. Yagnik, for that kind introduction. Good evening, friends. Let me thank the organizers for this invitation. Well, as you rightly said, it's the combination of diabetes and obesity, and that's a very deadly combination. It's like an unspoken epidemic, and it's all around. If you stand on the road and you start looking at people's bellies, you just see obesity, but if you go and sort of talk to him, you might find he's a diabetic. These are my disclosures. Now, we live in the midst of modern day epidemics, and several of them, which include obesity, pre-diabetes, cardiovascular disease, type 2 diabetes. And the combination there of type 2 diabetes and obesity is diabesity. And unfortunately, you're seeing this occurring very early in life, youngsters, less than 30, of course, middle-aged and elderly. The second sad part about the whole thing is that it is rising in the developing countries. And there is much more rise in the developing countries compared to the developed world. So in addition to the pandemic that we are all facing, look at what we are already in there and what we have. And that's why the previous two talks paid some attention. Dr. Michael Herman's talk also said, people with diabetes will be there. So you've got to be very, very careful. Now, these are figures for obesity, and these are highest rates of obesity. India is fourth largest, highest rates of obesity. Almost 73% of urban Indians are obese. About half urban Indians are overweight, age 28 to 38, but that's not a standard figure. And all of you know that India is the number 2 country as far as the numbers of people with diabetes is concerned, 77 million in 19 and reaching to uncountable numbers as years pass by. So you've got a twin epidemic of obesity and diabetes. This definition will plague almost 366 million people by the year 2030. So you will be plagued by almost this large number, and 60% of these population have a genetic predisposition for development of either diabetes or obesity. And 2 of 3 of these patients are overweight. 1 out of 3 adults have pre-diabetes, and 1 out of 10 adult patients will have diabetes. And so the figures here show you all the things that you're consuming, the junk food and physical activity and so lots of other things. But look at what Elliot P. Jocelyn said in 1927. With an excess of fat, diabetes begins, and from an excess of fat, diabetics die. And he was able to predict this so many years ago. So there are several questions regarding the combination of these 2 epidemics that have some answers, but some don't have answers. So obesity leads to marked degree of insulin resistance, leading to type 2 diabetes, high insulin levels, obesity, and this vicious cycle continues. But what are the mechanisms linking these 2 disorders, obesity and type 2 diabetes? How do obesity and insulin resistance contribute to beta cell decompensation? And if you lose weight in people who got diabetes and obesity, would it have an impact on this beta cell function and glycemia? And would it reduce the incidence of type 2 diabetes? There are some questions to which not very clear answers are available. And why do all patients with obesity not develop type 2 diabetes? Something that has been labeled as metabolically healthy obese. So if you look into the history, you'll find that type 2 diabetes never travels alone. It comes in the history, it comes in the combination and cluster of risk factors, of which obesity is probably the most important. Then you've got hypertension, cardiovascular disease, and chronic kidney disease. This is data from our center, which shows the green bars show you visceral adiposity, which is present both in urban men and women, but now also seen significantly in rural men and rural women. If you ask them to take their clothes up, and you'll find otherwise they've got these loose clothes and you just miss it. And similarly, you can see the body mass indices also climbing up. So waist circumference and body mass indices of both urban men and women are increasing. And that's why several magazines have had these cover pictures of the girth of the nation. That's India Today. And that's the Time magazine, the 2 Indians, the impoverished Indian and the Indian who looks like somebody who's got abdominal adiposity, marked degree of overall morbid obesity, hypertension, and other risk factors. But it's just not the BMI. It's where the ectopic fat is. As you just heard an elegant lecture from, here you see this handsome young person sitting on your right, and your left is John Yudkin. And this study was published in Lancet in 2004. Both have the same body mass index, but look at the difference in body fat. 21% with Dr. Yagnik and 9% with John Yudkin. And that's what the dangerous fat is called all about. So these visceral adiposity is leading to very different sort of adipokines. You've got the pro-inflammatory and the anti-inflammatory adipokines, like the adiponectin, which is less, and the pro-inflammatory adipokines like the IL-6 and all those things are markedly increased in people who've got high degree of visceral adiposity. So they've got excess body fat, they've got abdominal adiposity, increased abdominal fat and ectopic fat deposits both in liver and muscle. And that's what famously is known as the YY paradox. Now, what happens in a normal energy balance scenario? Energy is directed towards the subcutaneous fat, or is burnt in the mitochondria, in the liver and skeletal muscle. And this really protects you from the risk of type 2 diabetes and cardiovascular disease. But what's modern day environment and energy balance here? And you see here, poor physical activity, moving in the car, eating all that junk food, and all this leads to energy being deposited as fat intra-abdominally. And so you've got large visceral adipocytes, or what is called as visceral adiposity, And you've got harvest of this energy in the liver, muscle, and pancreas. And this ectopic deposition of fat leads to marked degree of insulin resistance at all these sites, and also to the high risk of type 2 diabetes and cardiovascular disease. Obesity-associated insulin resistance mechanisms are several. Some of them extremely well defined, as I mentioned, the pro-inflammatory adipokines and the anti-inflammatory adipokines. Then you've got defects at the mitochondrial level. Then you've got lipotoxicity, ectopic fat in the liver, muscle, and pancreas. And as I mentioned, it's very important where that fat is deposited. And so all these factors then lead to type 2 diabetes. These are hypotheses generated, but some of them are very well explained and some not so well. Coming to complications of diabetes, we all know that only having obesity is a major contributor to so many comorbidities. The most important being type 2 diabetes, but then you've got cardiovascular disease, you've got cerebrovascular disease, pulmonary disease, hepatic disease, gallbladder disease, cancers, gastroesophageal reflux, etc. And all this leading to type 2 diabetes, and then type 2 diabetes has all those complications which you are so well aware of, which includes micro and macrovascular complications and devastating complications of heart disease and higher mortality in people who got diabetes as compared to normal BMI type 2 diabetic individuals. Now, what happens if you lose some weight? If you lose just about 5% or more, you can prevent diabetes. You can have better glycemic control. You can reduce the number of anti-hyperglycemic agents that you're taking. And you also have improvement in cardiovascular risk factors. If you improve and lose more than 10%, you get improvements in what you did previously, but also improvements in sleep apnea, and sometimes also reports of diabetes remission. What happens if you lose more weight, more than 15%? You reduce cardiovascular events and also decrease all-cause mortality and reduction in cancer risk. So these are very important potential benefits. And I think, you should be paying a lot of attention in passing on these benefits and trying to tell them that even a loss of 2 or 3 or 4% of body weight can do real wonders to your patients. How do you manage diabetes? This is the most difficult part because you need lifestyle changes for the rest of the life of this patient, which include diet and exercise, behavioral therapy. I think it's more to do with counseling, motivating. Motivational therapy is behavioral therapy. You've got to motivate him to lose weight. And these have to really go into sessions, not one conversation with the patient. Exercise, 35, 40 minutes of daily exercise. Now, what's the role of pharmacotherapy? Well, pharmacotherapy would be needed if you have comorbidities and if your body mass index moves over 25. And over 25, I think everybody would need some form of pharmacotherapy. Bariatric surgery would be needed in some individuals where nothing works. And in Asian Indians, a cutoff of about 32 has been proposed. Now, but I would say the primary prevention of diabetes would be prevent obesity, prevent diabetes. Now, the Look Ahead trial very clearly showed that if you have intensive lifestyle management, you might not be reducing cardiovascular risk factors, but you would definitely be reducing the risk of getting diabetes and weight loss. And that is the most important. And this study very clearly showed that for several years, you would be able to help patients lose weight. Of course, there were some improvements in cardiovascular risk factors also. But you can see the weight loss was almost 6.15% in people who were put on intensive lifestyle management. Now, a major problem that occurs in people who are being treated for diabetes is their type 2 diabetes therapy. And this is data from all the studies that you can remember immediately. Look at UKPDS. People gained 9.9 kilograms. Look at TCCT. And here you can see it's 5.3 sulfonylureas. You use them every day. DCCT 4.7, sulfonylureas more than 10 kilograms in the Accord trial, glitazones 4.8, glyburide 1.6. And what happens? This increase in BMI every year can increase your risk of CVD mortality by 12%, can increase your risk of heart failure. If you just increase 1 kg, you increase your risk of heart failure by 7%. Every 3 kilogram gain offsets the benefit that you get by reducing 1% of your HbA1c. 2.25% increase in incidence of CV risk. So all forms of weight gain that your patients get during type 2 diabetes therapy has to be kept in mind when you are treating people with diabetes. That's very, very important. So look at these modern day therapies. These are the therapies that you had till about 2007, 2008, when the incretin therapies, first the GLP-1s came, but then the DPP-4s came, which really had no impact on weight. But as soon as the GLP-1s came in 2008, 2007 end, and 2008, the DPP-4 entered, and then the SGLT2s arrived two years later, you could see the effect on weight was so significant. It was not only an effect on weight, it was effect on several important factors, which we look at in our people. That's effect on cardiovascular risk reduction, on kidney function, on heart failure, in addition to no risk of hypoglycemia and potent glycemic control. So the modern day therapies of SGLT2 inhibitors and GLP-1s have really changed the paradigm of type 2 diabetes therapy, especially therapy for diabetes. Now here are the SGLT2 inhibitors. Look at, I'm just trying to show you the higher doses of the SGLT. Look at canagliflozin, 300 milligrams. Compare it with the highest dose of dapagliflozin and empagliflozin. And you can see the difference of decrease in body weight. Look at here canagliflozin giving you a sustained good weight reduction for almost 104 weeks. So a Cana 300 is more powerful than Cana 100, but is still more powerful than a DAPA and an EMPA2. And here is data to show the clinical, a composite target of HbA1c and weight, which we are looking at when we are treating people with diabetes. You're trying to control his HbA1c, you're trying to control his weight. And this data on the upper panel shows you comparison of canagliflozin versus the sitagliptin shown in gray, a canagliflozin 300 shown in maroon bars. And you can see the difference in people getting body weight reduction of 3%, a large composite of reduction of both HbA1c and weight. And the lower panel shows you comparison with glimepiride. The panel on the right shows that these drugs also help you to lose fat mass, which is so important, deposited in the wrong places that you have. Now here is comparison of canagliflozin 300 milligrams getting a body weight reduction of almost 3.4 kilograms and HbA1c of 0.92. And the lower bottom shows you a 25 milligram empagliflozin getting you an HbA1c reduction of 0.7 and a weight reduction of only 1.4. So this drug naturally is more powerful. And are all SGLT2 inhibitors equal? Well, this is from the prescribing information of all these molecules. A Cana 100 gives you a 100 milligram glucose loss every day as compared to the others, which give you 70 and a little less. But what are the mechanisms? This works at the extracellular level where it transiently blocks the SGLT1 and delays the glucose absorption. So before the drug is absorbed, it just inhibits the SGLT1. And this SGLT1 inhibition also leads to an increase in GLP-1, 35% increase in circulating GLP-1s. And so GLP-1 again helps you to get the blood sugar down. You've got renal mechanisms because it's more powerful. It gets you 25% extra urinary glucose excretion. You get almost 24-hour coverage. And there is also supposed to be some delay in gastric emptying, which helps you to get a better glucose control in addition to the weight loss that it tells you. Now here is the effect of GLP-1s on HbA1c and body weight. And this is data from Michael Nock. and where he's tried to show short-acting versus short-acting GLP-1. So exenatide compared to lixisenatide, short-acting versus long-acting liraglutide versus exenatide, and there you've got the long-acting versus long-acting. The upper panel shows you HbA1c reduction, and the lower panel shows you body weight reduction. So all these forms of the long-acting GLP-1, especially the weekly ones, are doing wonders in patients because of their dual effect on good HbA1c control and body weight control. And that's exactly what we need in the management of diabetes. Now, if you combine the two, you get additive effects. You get synergistic effects on body weight and also improvement in glycemia, in addition to several other factors that this combination really helps in people who got diabetes. Now, here is our real-world evidence, which we published in Diabetes in 2018, a combination of dulaglutide weekly with canagliflozin. And these people had a body mass index of 33, 34, and these are all people who had HbA1c of more than 8, a body mass index of more than 27, with a normal renal function. And what did we see? We saw that by week 16, these patients had HbA1c fall of 1.4, but another 0.3 was lost in 32 weeks, so a total of 1.7% body weight reduction. And similarly, the right panel on the lower side showed you that the first 16 weeks, the combination gave you a decrease of 4.1 kilograms of body weight. In addition, another 3.3 kilograms by the end of 32 weeks. So the patient had lost 7.4 kilograms in totality. So this is the wonder that these two molecules can do. And that's why I said that this has been a paradigm shift in management of people with diabetes. Not only that, it changes your systolic blood pressure, gets you improvement in cholesterols and triglycerides. Now, these are anti-obesity therapies currently recommended for chronic weight management. Orlistat has been available for ages in this country, but the drug is difficult to use because of its side effects. So somebody who's trying to use it for a short term, then phentermine plus topiramate is available. But for longer use, the lower two are available, which is liraglutide 3 milligrams and naltrexone sustained release plus bupropion sustained release. But these all have some side effects, and that's why they've not really become very popular, other than liraglutide. The right panel on the top shows you comparative efficacy of phentermine, liraglutide, and naltrexone. And you can see liraglutide can get you a weight loss of almost 6 kilograms. That's 3 milligrams of liraglutide. The FDA has also approved the higher doses of dulaglutide, the Trulicity molecule, and 3 milligram and 4.5 milligram have been approved based on the AWARD 11 trial. So this gets you a 1.9% reduction in HbA1c. And you saw my real world evidence showed you a combination of only 100 milligram of canagliflozin and 1.5 milligram could get you that weight loss. But what happens in these AWARD trials, you can see 3 milligrams and 4.5 milligrams really helping these patients. Of course, then some people will end up with bariatric surgery. You may do what you like, but then there will be some people who will be eligible for surgery, especially people on that higher end of body mass index. Sometimes you can't tolerate these drugs. And so you'll have to really think of surgery. And there are several forms of surgery. We're not going into those details. But then these will also have their problems like malabsorptions and return of diabetes after some years and some change in weight after some years. So everything has its own challenges and benefits and side effects. So friends, diabetes has assumed epidemic proportions. Insulin resistance links obesity and diabetes. When you would be trying to manage diabetes, you'd require behavioral therapies. That's the most important. Lifestyle intervention and behavioral therapies. And these therapies will have to be long-term. Nothing short-term will work in these patients. You've got to use anti-diabetic agents which promote weight loss and decrease HbA1c. And that's why the two newer molecules really do well. The higher strength of these molecules, like the canagliflozin, the GLP-1s, will really work well in combination. And some patients will require bariatric surgery. So if you've got to really fight diabetes, you've got to fight obesity and prevent diabetes and break this vicious cycle and reduce the risk of diabetes in the populations to come. Knowing is not enough, we must apply. Willing is not enough, we must do. Thank you very much for your attention.
Thank you, Dr. Nigam. Thank you for a very good presentation and a very good insight about the diabetes. That your take-home message is excellent. That the combination of a weight reducing anti-diabetic drug is a need of an hour. Thank you very much. And is there any question, Dr. Rupam?
Yes,
any
sir.
question in chat box?
I don't see any question in chat box yet.
Okay.
So in the chat box, only the speakers or faculty are there. From the delegates, you get the questions directly to the event organizers, and the event organizers can write to you. So Rupam or Rutul, you can ask directly Hardik if somebody had asked from the delegates, because in this, only the 15 participants, they are only the faculty or the next session faculty or the reporter. So you will not get the chat box questions directly from the delegates. But if you have any questions, you can ask.
Let me ask if there are any questions from delegates. Yes.
Right.
No, sir, there is no question from delegates.
Okay, thank you, Arshit. Thank you.
If you allow, may I ask a question to Nigam sir?
Yes.
Yeah, you're Dr. Rupam.
Yeah, Nigam sir, we have been talking about remission of diabetes for so long, and there are papers that also suggested that remission is possible. So how do you think, what is your take on remission of diabetes? In how many percentage of patients we can really achieve that remission, and what are the mantras behind achieving remission in our patients?
I think that's an excellent question, but a very difficult answer is that these are things that will require lifelong management. It's not something that you can stop. And if you stop, be sure it's going to come back. So something that will require a lifelong intervention on the part of the patient, on the part of also the physician, in the form of behavioral therapy, or as what you called as motivational therapy, helping him with lifestyle intervention changes, which include diet, physical activity, and being positive and removing stress, and environmental factors, and so on. In fact, this is the most difficult. And even when you're doing something like a bariatric surgery, or you're using these combination therapies, the moment the patient stops these therapies, he may continue, because he spent so much of money, he may continue following diet, exercise, and all these things for a couple of months. But then life is so busy, and everybody said that the most difficult thing is lifestyle management. When you get a person with newly diagnosed type 2 diabetic, and you say, okay, manage your lifestyle, I'm just giving you metformin, and come back after 3 months. So he's heard you today, he'll be very positive for the first 4 weeks, next 4 weeks, and by the time he comes back to you after 3 months, he's only continuing metformin, but his glycemia has gone up. So, these things are very easily said than followed, and very difficult to see what happens later on.
Exactly, sir. Many times what happens is we tend to stop the medications, seeing a good HbA1c for 2 subsequent, 3 months, probably 6 months. And then again, what happens is, again, after 6 months, HbA1c becomes 9%. So very difficult practically to imply all this.
That is exactly what I said. It's very, I would say, I wouldn't consider even prescribing somebody like this and saying, come, only lifestyle. No, lifestyle is not going to work. It's like a new person going to a church or a mandir, and saying Ram Ram. But then he will forget that very soon, because lifestyle is the most difficult. How many times are you able to exercise? Let's ask ourselves, how many times are we able to exercise as doctors who know everything in a week? That's very difficult.
Okay, thank you. Thank you, Dr. Nigam. And at the end, I thanks all the speakers, Dr. Yagnik, Dr. Michael, Dr. Nigam, and the organizer, especially Dr. Bansi and his whole team for organizing such a beautiful event and such an informative educational event. Thank you. Thank you so much.
Thank you very much.
Over to our next event.
So Dr. Michael.
Yeah.
I'm going to drop now and then join later. Thank you very much.
Yeah. Thank you very much, sir. We have reporter Dr. Raka Shivhare for next session. You are here, Dr. Raka?
No, sir. You can introduce the first speaker and start the session.
Okay. So please put the slide for our first speaker. So our first speaker for today's talk of NAFLD and diabetes underestimated risk is Dr. Jayant Panda. He is professor and head PG Department of Medicine, SCB Medical College, Cuttack. Member of governing body API. Dr. Jayant Panda is a diabetologist and a critical care physician based in Cuttack. Dr. Jayant Kumar Panda research interests include in the field of diabetology and endocrinology. He has also served as an editor of journals such as Orissa Physicians Journal and the Orissa Medical Journal. Over 40 papers and articles authored by Dr. Panda on subjects relating to internal medicine and diabetes have been published in national as well as international journals. So I invite you, sir, for your talk.
Thank you, Rutul. I'm sharing the slides. My slides are visible?
Yes, sir. Yes.
So thank you, Chairpersons. Thank you, Rutul. Thank you, whole team of Diabetes India. It's a very great moment that in the absence of our beloved Sadikut sir, we have continued the show. And I must thank Dr. Banshi, my good friend, Dr. Arvind, our guide, and the whole team, Anup Shar and the Amit, and the whole team for continuing the rapport. And I'm very proud to be part of Diabetes India. I have been assigned the topic NAFLD and diabetes underestimated risk. And this, all of you know very well that this is a field where we are not very conscious. So at the end, I'll give you what really we need to practice and how we should go about. So to define few things, there are terms like NAFLD, NAFL, NASH, and then there are situations, related definitions like NASH and cirrhosis, cryptogenic cirrhosis, and the NAFLD activity score, which all of you are acquainted with, all gastroenterologists, the endocrinologists, diabetologists, metabolic physician present in the gathering. And my most important saying that if you come across a patient of diabetes, like you screen for microvascular complications, you screen for macrovascular complications, also screen them for important complications like non-alcoholic fatty liver disease. So liver disease is an important cause of death in type 2 diabetes, which many of you have not realized by now. I'm telling how. There is a 2.5-fold risk of death from CLD, which was observed in a cohort study with more than 7,100 patients of type 2 diabetes. And recently a last study of more than 1 million subjects have confirmed that one of the important cause is NAFLD. 96% patients with cirrhosis have glucose intolerance, and 30% may be clinically diabetic out of them. Virtually the entire spectrum of liver disease is seen in patients with type 2 diabetes, namely the steatohepatitis, the cirrhosis of liver, and also the fatty liver. Liver disease occurring as a consequence of diabetes because of glycogen deposition, the steatosis and the non-alcoholic steatohepatitis, fibrosis and cirrhosis, biliary disease, cholelithiasis, cholecystitis, and complications of therapy of diabetes like cholestatic and necroinflammatory complications. And you know very well, it's a abnormality of glucose homeostasis occurring in a complication of liver disease, including hepatitis, cirrhosis, hepatocellular carcinoma, fulminant hepatic failure, and post-orthotic liver transplantation has resulted. And liver disease occurring coincidentally with diabetes mellitus and abnormalities of glucose homeostasis results in hemochromatosis, glycogen storage disease, and autoimmune biliary disease, which is an extension of the same problem. I am showing you some evidence that the cumulative risk of chronic non-alcoholic liver disease, including cirrhosis, shows very clearly that this NAFLD was significantly higher in patients of diabetes. You can see in this graph, diabetes have a very higher score. So also the cumulative risk of hepatocellular carcinoma, which is much significantly higher in patients of diabetes than non-diabetes. This tells us very clearly that we have to be very cautious about such complications. And here, an interesting finding, the incidence of cardiovascular disease in patients with NAFLD in selected longitudinal studies shows the CVD is the most common cause of death in most of the patients of NAFLD, cirrhosis, and end-stage liver disease. And you can see almost 1/3 of the patient die of the related cause. So CVD causes are a very common association of NAFLD. So finally, it is linked all complications. Let us learn little about pathophysiology. The major risk factor, like truncal obesity, which are commonly type 2 diabetics we see, and insulin resistance is there, and hypertriglyceridemia and metabolic syndrome are accompanied, which results both in NAFLD as well as in diabetes. And the conditions like hypothyroidism, obstructive sleep apnea, hypopituitarism, hypogonadism, pancreaticoduodenal resection, and polycystic ovary syndrome has in common both the conditions NAFLD and diabetes. And to reiterate, I'll tell it's a underestimated risk now. So diabetes is a risk factor for NAFLD and hepatocellular carcinoma. It comprises a series of liver disorders like steatosis to steatohepatitis, fibrosis, and cirrhosis. And it has been observed that the fatty liver, obesity, and insulin resistance act as cofactors to cause liver damage. You see here, the diabetes, obesity, and hyperlipidemia simultaneously contribute to NAFLD, which leads to cirrhosis and hepatocellular carcinoma. So if you tell your patients that the simple fatty liver can lead to carcinoma and you have a malignant risk and dying from that, many will not believe. Even physicians disagree on this point. But we have to realize that this is a potential risk. And all these factors, increased free fatty acid leading to adipose tissue and adiponectin, the leptin and TNF-alpha leading to oxidative stress, the hyperinsulinemia leading to increased free fatty acid, and the type 2 diabetes and hyperglycemia leading to hyperinsulinemia ultimately causes inflammation, necrosis, and fibrosis. This is regarding pathophysiology. And one thing I'll tell here, the screening in primary care diabetes center and obesity clinics is recommended. Adults attending this clinic should be screened to get worked out for NAFLD, and managing them in the right time with exercise, drugs, weight management will be rewarding in later in the prevention of the disease. Let us see the diagnosis. It requires this approach to diagnose NAFLD. We have to see if there is a hepatic steatosis by imaging or by histology. Many don't agree for histology, so imaging is a very convenient way. No significant alcohol consumption that you have to rule out. No competing etiology for hepatic steatosis that you have to rule out, and no coexisting causes of chronic liver disease. The biochemistry, you know, the AST, ALT, and other enzymes will do, and they rarely exceeds 4 to 5 times. Usually the ALT is more than AST in non-alcoholic fatty liver disease, and AST becomes higher when there is advanced fibrosis. The fibrosis score is taken, and you have to employ 6 easily available variables like age, hypoglycemia, body mass index, platelet count, albumin, and the AST-ALT ratio. And then it's most important to get a NAFLD fibrosis score. So less than 1.4 at 90% sensitivity and 60% specificity to exclude advanced fibrosis, and greater than 0.6 had 67% sensitivity, 97% specificity to identify presence of the fibrosis, which ultimately is correlated to the dysregulation, hypoglycemia, uncontrolled NAFLD, steatohepatitis, and chronic liver disease. If you see the CK18, the hepatocyte apoptosis plays an important role in the pathogenesis of NASH. It leads to increased serum cytokeratin 18. And in imaging, all are included: the abdominal ultrasound, the non-contrast abdominal CT, the contrast enhanced CT, abdominal MRI, and the transient elastography is an ultrasound-based non-invasive method of assessing fibrosis through measurement of liver stiffness. And you know about the FibroScan, which we have already talked about. The biopsy, which is the gold standard for characterizing the NAFLD, though expensive and carries risk of morbidity, very rarely mortality, assessing the degree of inflammation and shell injury, and to stage for the degree of fibrosis. You can see some pictures where the vacuoles are seen, a loss of hepatic architecture is seen, and also seen the fatty vacuoles are disseminated throughout the liver tissue, and a lot of lymphocyte infiltration. So this picture specifically tells us about non-alcoholic fatty liver disease in patients who will, you go for a biopsy safely, and that is the final gold standard of detecting an NAFLD in a patient of type 2 diabetes. We come to management, treatment of the patients with type 2 diabetes and the liver disease. There are two aspects I'll be covering. One is management of diabetes in patients with concomitant liver disease. One is management of liver disease in patients with concomitant diabetes, because this is a comorbidity. So when diabetes and NAFLD is there, both contribute to the another. The NAFLD contributes to diabetes and diabetes contributes to NAFLD. And in the management, also you have to be careful when the duo is approached. First, the liver disease in diabetes. The weight reduction surgery is very important. There occurs significant improvement in steatosis and ballooning in 1 and 5 years following bariatric surgery compared to baseline. Multiple benefits are seen and recommended in patients of morbid obesity to go for a weight reduction surgery. And weight loss generally reduces the steatosis, achieves the hypocaloric diet alone or in conjunction with the increased physical activity. So that is a very rewarding experience. And I'm not going to the details of the surgery, which is beyond the scope of this presentation. Along with that, the vitamin E can be taken for the antioxidant property, which is another option because we have very nominal players for intervening NAFLD associated with the diabetes. Here, this PBNS trial shows the outcome and changes in histologic features of liver after 96 weeks of treatment with vitamin E and pioglitazone. We can see significant improvement in NAFLD, and I'll recommend both the drugs in these patients of type 2 diabetes associated NAFLD. So this also tells you about the alpha tocopherol administration, the daily dose of 800 international units, which improves the liver histology, and that can be taken as a evidence, and we can practice in our patients who have this problem. Let us see about insulin sensitizing agents. The insulin resistance is believed to play an important role in the pathogenesis of NAFLD, and then many trials have shown that intervening this insulin resistance is rewarding in management of these patients of type 2 diabetes with NAFLD. And metformin has no significant effect on the liver histology and not recommended as a specific treatment for the liver disease. So this is one of the conditions. We know our good friend metformin is always there for us, but Here, with an advanced liver disease or an advanced NAFLD, when we use metformin, it can deteriorate the situation, deteriorate the NAFLD, though it may help our insulin resistance. So here, the pioglitazone is rather beneficial than the azole metformin. And statins and omega-3 fatty acids and also deoxycholic acids, the dyslipidemia is almost universal in these patients. So the histological endpoints that have examined the use of statins in the treatment of NASH, specifically to treat NASH, cannot be advocated at this point of time. If the patient has associated dyslipidemia, we give statins, but per se in NAFLD, we don't have much evidence. And the demonstrated improvement in liver test with an increase in liver-related adverse effects compared with the controls are seen, especially in the patients who have been used with the statins, omega-3 fatty acids, and also deoxycholic acids. So this double-blind trial shows borderline improvement. So some studies have shows the efficacy of UDCA in these situations, though they are not very promising. So we have studies which clearly not recommend the UDCA for this purpose, which is published in the hepatology, like what I am showing you now. It's premature to recommend the omega-3 fatty acid as well, but as a supportive drug, people have taken that and considered as the first line agent to treat hypertriglyceridemia in the patient with NAFLD. So if the patient has an associated hypertriglyceridemia, we can aid the omega-3 fatty acid. If the patient has associated dyslipidemia, we can aid a statin, and of course UDCA has some controversial role. The lack of evidence to show that the patient have an increased risk of serious drug-induced liver injury from statins. The RCTs, they recommend the use if there is associated dyslipidemia. Alcohol use in these patients. It should not consume heavy amount of alcohol, and it's not recommended can be made with regards to non-heavy consumption of alcohol as well. Though they are not habitually alcoholics, and the liver damage is not classical of alcoholic liver disease. In general, they are advised not to take because they have already a liver pathology existing. The miscellaneous recommendations, they tell the screening for the HCC, and they don't support a routine repeating of the liver biopsy in the patient of NAFLD or NASH. So going for a biopsy regularly is not recommended, but you can go for endoscopy to see the evidence of esophageal varices. I have already told that the first line therapy with metformin is not recommended in advanced hepatic disease, but it has not been reported to cause hepatotoxicity and has shown some benefit in patients of NAFLD as well. So in the early stage, you can think of giving metformin, but patient with significant NAFLD, steatohepatitis, and in the SCC, we have to avoid this drug, and preferable drug is insulin. This is regarding management of diabetes in patients of concomitant liver disease. Let us discuss the drugs which help us for the management of diabetes and also NAFLD, and then they have role in decreasing NAFLD. The sulfonylureas, our old friend, in the management of diabetes with concomitant liver disease, are safe. May not overcome the insulin resistance. They don't work on that. The defects in the insulin secretions in patients with coexistent alcohol liver disease and pancreatic damage, and then with a short half-life, sort of like glipizide and glyburide are preferred in this condition than glimepiride. So glipizide and glyburide we prefer, which have a short half-life and that usually don't cause hypoglycemia. With decompensated cirrhosis, they have a reduced ability to counteract the hypoglycemia, and thus the response to the therapy should be monitored. And the chlorpropamide was associated with hepatitis and jaundice, that all of you know why this drug was banned. Here, the alpha glucosidase inhibitors are particularly useful in patients with liver disease because they frequently cause mild transient elevation of ALT. Rare occasion, the severe liver disease, but shown to be effective in encephalopathy as well as in cirrhosis. Migletol has not been associated with hepatotoxicity. The glycemic control improved significantly in both fasting and postprandial state because of the low glycemic load and low A1C. And type 2 diabetes treated with insulin along with alpha glucosidase inhibitor. The similar effects in the patients with hepatic encephalopathy, also a reduction in the blood ammonia level, which paralleled and increased bowel movement frequently. Glitazones I have already told, especially useful because of the enhanced insulin sensitivity. They are sensitizers and they work on underlying defect of NAFLD. Concern about their potential hepatotoxicity due to experience with the troglitazone, but no difference in the incidence of liver abnormality has been reported with pioglitazone, and they're not to be initiated if there is evidence of active liver disease or if the serum ALT is more than 2.5 times high. Insulin is the final answer, and frequently it is required, and when there is a significant CLD, we insist the patient to go for insulin because they work in many ways. They're anti-inflammatory, they improve the NAFLD, they improve the A1C, and it can be very well correlated with the improvement of the both associated conditions. And with decompensated liver disease, the requirement may be decreased due to the capacity of gluconeogenesis and reduced hepatic breakdown of insulin, that you have to know, or else will end in hypoglycemia. And the patients with impaired hepatic function may have an increased need for insulin due to insulin resistance. Finally, in patients with hepatic encephalopathy who require high carbohydrate diets resulting in postprandial hyperglycemia, rapid-acting insulin analogs like Lispro, Aspart, and glulysin may be particularly useful, and they help us in controlling diabetes very well. So with this, ladies and gentlemen, I have covered the topic, the NAFLD and diabetes, the underestimated risk. Many times we forget to screen NAFLD in a diabetic patient, and the most importantly, the complications like steatohepatitis and also hepatocellular carcinoma has to be kept in mind, and we have to be sure that the metabolism, which is common to diabetes and the liver, the gluconeogenesis and the glycogen storage shares the complication, and we have to be very careful while dealing a patient for detecting, intervening, and successfully managing both cases in a patient. Thank you for the time, and thank you for the opportunity.
Thank you very much, Jayant Panda sir, for wonderful talk. And next, I would like to invite our next speaker, Dr. Sanjay Bharara. He's from Chandigarh, and his topic is less known facts of bone health in diabetes. So his area of interest, metabolic bone disorders and diabetes. He is secretary of Punjab and Chandigarh chapter of RSSDI. He is DM Endocrinology, FICP, FRICPI, MNA, MS, FA, MS, ex-National Executive Secretary and Indian Society for Bone and Mineral Research, actively involved in teaching and research, more than 200 publications in peer-reviewed journal from him, research collaboration with the National, IIT Ropar, CDRI Lucknow, AIMS New Delhi, Punjab University, and IM Tech Chandigarh. Internationals like Henry Ford Hospital, Detroit, USA, and Antwerp University, Belgium. Recipient of MN Sen Oration Award ICMR 2013 and PN Shah and Subhash Mukherjee Oration Endocrine Society of India 2010 and 2016 respectively. Professor Surveer Singh visiting professorship in Association Physician of India in 2011. So I hand over the session to Dr. Sanjay Bharara, sir.
Let me share my screen. Thank you, Dr. Rutul, for the a kind introduction, and let me share the screen. Well, my screen is visible.
Yes.
Let me make
Yes, sir.
Or
Visible, sir. Visible.
okay. Hope my screen is visible.
Yes, sir.
I'm audible. Okay.
Yeah, audible.
Thank you, Dr. Rutul, for the kind introduction. And at the outset, I would like to thank Diabetes India Organizing Committee and my friend Dr. Bansi and the team for giving me this opportunity to talk on a topic, bone and diabetes, not commonly heard, at least a decade back or maybe in last 2-3 years. Few publications are coming from India and some gaining some ground in the field of the diabetes mellitus. So what I'm going to do in next 15 minutes is that I'll show you the data that is there any fracture risk increase in diabetes mellitus? What is pathophysiological insights in the diabetes and bone health? And the two important parameters of bone health are bone quantity and quality, how it is affected by hyperglycemia. And then obviously muscle is an important aspect of the bone health. So role of sarcopenia and some fracture risk estimation in diabetes mellitus. And finally, one slide on the treatment also. So we all know that hyperglycemia affects almost every organ system of the body, whether it is kidney, nephropathy, retinopathy, neuropathy, coronary artery disease, or the heart failure and the stroke. But one of the major organ of the body is often missed, and there is very little information is available, or we are not talking frequently, that is the skeleton. And the skeleton contributes almost 10% of the responsible for 10% of the cardiac output, but nobody talks about that. Maybe in down the years, we see that another microvascular complication of diabetes is the bone health. And a lot of people are working in this field. So let's go to what is the risk of fragility fracture in type 2 diabetes. So in a very beautiful meta-analysis, and that is showing very clearly that patients with type 2 diabetes are at the risk of increased fragility fractures, and that is significant. It is almost 1.7 times more frequent as compared to the non-diabetic individual. The situation is even more grim in type 1 diabetes, and you can see that in type 1 diabetes, the risk is increased almost 7 times as compared to the normal individuals. Though in India, we are not seeing many patients with the fracture in type 1 diabetes, because if you look at our mean survival of diabetes in India is around 30 to 40 years. And most of the studies, those are done, it is after the 40 years where we expect the patient will develop the fracture. Looking at the overall scenario with the fracture risk, the various sites, hip fracture, wrist fracture, and spine fracture. So you look at the hip fracture, in type 1 diabetes, it is almost 1.7 times more frequent. And in type 2 diabetes, also equally more common at the hip fracture in patients with type 2 diabetes. Even bad in case of spine fracture in type 1 diabetes, 2.5 times more fractures are there, and in type 1 diabetes almost 1.5 times. In this, while reviewing this literature, now we are sure that the patients of type 2 diabetes or type 1 diabetes are at the risk of developing fragility fracture. So now look at what are the mechanisms, the reason where responsible for the increased fragility fractures in the patients of type 1 or type 2 diabetes. And we all know that bone is a tissue which is continuously in the setting of the remodeling. And this remodeling takes place with the help of three type of cells basically. One is the osteoblast, another is osteoclast, and the osteoblast and osteoclast activity is actually monitored by the another cell that is called the osteocyte. And we all know that osteoblast is responsible for the bone mineralization, while osteoclast is responsible for the bone resorption. The critical balance between osteoblast and osteoclast is very, very important to have the good bone health. So what happens in the type 2 diabetes is because the osteoblast activity is reduced and the osteoclast activity is increased. So osteoclast activity is increased, that is because of the multiple mechanisms, cytokine related, that is because of hyperglycemia per se, because of advanced glycation end product. While the osteoblastic activity is reduced because of reduction in the level of insulin-like growth factor, that is especially significant in type 1 diabetes, then insulin deficiency, reduced amylin levels. So these are the multiple regions, those are responsible for the inhibition of osteoblast. And then certain other mechanisms like increased adipose tissue that lead to the leptin, and that is ultimately causing the bad effect on the osteoblast. And there is reduced level of adiponectin in type 2 diabetes, further it is negatively affect the osteoblast. So in nutshell, we can say that in case of hyperglycemia or diabetes, the osteoblast, which is the bone forming cells, are their activity is reduced, while the osteoclasts, those are responsible bone resorption, their activity is increased because of the multiple reasons. On the top of that, we all know that diabetes mellitus is associated with the hyperglycemia, and that hyperglycemia ultimately responsible for the generation of the advanced glycation end products. And these advanced glycation end products are also accumulated in the bone, and these advanced glycation end products are like carboxymethyl lysine and the pentosidine. So these advanced glycation end products are having direct effect on the bone collagen, and so that leads to decreased collagen fibril deformation. And that is one example of that is the prayer sign, or the collagen is not deformed or is not required to modulate itself. And the indirect effect on the bone remodeling of this advanced glycation end product is the reduced blastic activity. Because of this collagen fibril deformation and because of the bone that ultimately culminates into bone tissue fracture in the patients of the diabetes mellitus. Another gut microbiota and bone health in type 2 diabetes or in diabetes. So that is, we all know that in case of dysbiosis, there is increased intestinal permeability is there, and because of this increased intestinal permeability, there is increase in the level of the lipopolysaccharides or decreased level of the small chain fatty acids. This increased level of lipopolysaccharides and decreased level of SCFA ultimately results into the this LPS increase leads to the level of nuclear factor kappa beta, that is one of the cytokine. And while decreased level of the small chain fatty acid, that results into reduced level of the GLP-1. In turn, that leads to increased osteoclastic activity and reduced osteoblastic activity. So this gut microbiota alteration in the diabetes might be also playing a role in the poor bone health in diabetes mellitus. Another less known fact about diabetes and the bone relationship is that bone and beta cell axis. So we all know there is a bone marker that is known as osteocalcin. So osteocalcin actually comes from the bone, and in the bone from the osteoblast. The osteoblast secretes the osteocalcin, and osteocalcin actually stays in two forms. One is the carboxylated form, and another is undercarboxylated or uncarboxylated form. So undercarboxylated or uncarboxylated osteocalcin is actually in a active osteocalcin, and this active osteocalcin has a many effect on relation to these various organ system. And the initial effect is there on the beta cells. It acts on the osteocalcin, acts on the beta cells to the GPRC receptor, and that it secretes the insulin. So that is bone and the beta cell axis. Then this undercarboxylated osteocalcin also acts on the small intestine, and from it releases the GLP-1. It also acts on the muscle directly, and it reduces, basically helps in the glucose metabolism. It also acts on the adipocyte, and it helps in the release of the adiponectin, which is, we all know that is the insulin sensitizer cytokine. So ultimately, this undercarboxylate osteocalcin responsible for the improved glucose metabolism. So if there is any problem over here, then osteocalcin is less synthesized, or in that case, then the glucose metabolism will be affected. Though this all hypothesis is to be studied even the at the clinical level, but there the information is available is like this. Now coming to the after understanding the pathophysiology and the mechanism, that what happens to the bone actually. We know that bone strength is mainly dependent on two things. That is, one is the bone quality, another is the bone quantity. I'll talk more on the bone quality because a lot of things are known about the bone quantity, but less is known about the bone quality. So in my subsequent slide, I'll talk more on the bone quality. So first on the bone quantity. So it is known that type 1 diabetes patients are having low bone mineral density. Type 2 diabetes patients are, traditional teaching is that the BMD is normal or high, but there will be various studies in favor and against that from India itself also. That two studies are favoring that patients with type 2 diabetes are having the comparable bone mineral density as compared to the controls, while other studies are telling that BMD is high in the type 2 diabetes in the US. But remember, all these studies are based on the DEXA scan, and the DEXA scan has the problem that it cannot measure the cortical porosity properly, and that's why probably it is giving the high bone mineral density. So I'll try to answer this question, that what actually happens to the bone mineral density in patients of the type 2 diabetes. Another thing is that what happens to, especially with the bone health in the Indian scenario. So the typical Indian patients of type 2 diabetes, then the central obesity, younger age of onset of diabetes, more central obesity, higher insulin resistance, and because of this higher inflammatory markers are there. And these, because of the higher insulin resistance and high inflammatory marker, there is more to the bone damage. And the younger age of onset of diabetes, that's why there is peak bone mass is also not achieved adequately, and peak bone mass is low as compared to the Western population. And these all ultimately results in diabetic bone disease. On the top of that, another factors those are responsible the poor bone health in the Indians is that early age of onset of menopause. In India, menopause is approximately 42 to 45 years, while in case of Western country it is 50 to 55 years. So early menopause further contributes for the poor bone health, not in diabetes, but otherwise also. And then high prevalence of vitamin D deficiency, and we know all that type 2 diabetes individuals are more adipose tissues there, and that's why they are more prone for the inflammatory cytokine level and this more severe diabetic bone disease. Now coming to the, after talking about the bone quantity, I'll talk briefly about the bone quality. And the bone quality is determined by many factors. One is that protein content and protein secondary structure is important for the bone quality. Then bone microstructure is another important thing. And then advanced glycation end product. Though there are multiple factors, those are responsible for the bone quality, but this is one of the more important factors. So I'm sorry for this busy slide, but this slide I'm just trying to explain you that you can study the bone health at the multiple level. At the macro scale, meaning by that you can study whole bone. At the meso scale level, you can study the in the millimeter to 5 to 10 millimeter size tissue. The cortical bone and trabecular bone can be studied. At the micro scale level, where this 5 micron to 500 micron micrometer, you can study this with the various modalities, and that we study the osteon and the trabecula of the bone. At the nano scale, you can study the collagen fiber, collagen molecules, mineral crystal size, cross-link, and all these things. So, and these are the various parameters, the microstructure, the porosity, the aerial BMD, the collagen, and all these things can be studied by this at various levels. So I'll take you this very nice publication in the recent issue of the Journal of Clinical Endocrinology and Metabolism, JCM 2021, with the help of our colleagues from the IIT Ropar. So what we did here is we selected 70 patients, 30 diabetes patients and 40 non-diabetic individuals. All these patients indeed sustained a fragility fracture. So during the hip fragility fracture, their head of femur was removed and they subjected for the hip replacement. So we collected these bones from the we compared these all various baseline parameters. Their vitamin C, calcium, vitamin D, calcium, phosphorus, PTH, and you can see all are comparable. There is no difference between these two groups. And when we looked at the DEXA scan for the femoral neck BMD as well as the T-score, that was also again comparable in these two groups. So you can say essentially these groups are comparable with these various parameters. So when we studied this tissue with the micro CT, so the micro CT, as I mentioned, you can study from 5 to 500 micron. And what we found is that bone volume was less in the diabetic individuals compared to the non-diabetic. Then the trabecular thickness also reduced in the diabetic individuals compared to the non-diabetic individuals. Trabecular separation is increased in the diabetic individuals as compared to the non-diabetic individuals. And just you can see, look at this picture, non-diabetic picture of bone, how it is looking like that versus the diabetic bone, how it is looking like that. So you can see a lot of fractures are there and the thickness is much less as compared to this part of the picture. So on the microstructure, we have shown that the BMD is better in non-diabetic individuals compared to the diabetic individuals. Then we looked at the composition. We found the mineral content was again low in the diabetic individuals as compared to the non-diabetic individuals. So these two things clearly proven that the mineral content in the type 2 diabetes is less as compared to the non-diabetic individuals. Further, we studied the nano indentation. Just nano indentation is a technique by which we assess the hardness as well. So the modulus depends on the collagen tissue, and the modulus is very important. If the modulus is less, the bone is more fragile. So again, we have shown that on the nano indentation that individuals non-diabetic are having better modulus as compared to the diabetic individuals, and the hardness was again better in the non-diabetic individuals compared to the diabetic individuals. So meaning by that, again, it is showing that BMD is less, that is determined by the hardness, but modulus is also less in patients of type 2 diabetes, and that predisposes them for the fragility fractures. So we know that bone biopsy is not easy task. So we recently published very interesting paper where we used the fingernail of these patients, and we found that fingernail also giving the similar kind of information. Now coming to the sarcopenia, we know that patients with type 2 diabetes are having high adipose tissue content, and that is associated with high inflammation, and that leads to the ultimately there is fat deposition in the muscles also, and that leads to decreased muscle mass, decreased physical activity, and the risk of fall is increased, and that is actually because leads to the sarcopenia. And this high adipose tissue having direct effect on the bone cells also, decreases osteoblastic activity, and increases osteoclastic activity, that finally culminates into the fracture. So fracture risk assessment can be done by the tool that is the FRAX. But just I want to show here is that you can use the FRAX, and that is a better way to use FRAX is that you can use the T-score rather than measuring the secondary osteoporosis. And in case of type 2 diabetes, FRAX can be used, but you have to modify a FRAX little bit. That is, one is either you can increase age by 10 years while you are mentioning age, or you can add rheumatoid arthritis, especially even not having, you have to add that, or you reduce the T-score by -0.5. So both these three things, out of these three, you can add one while you assessing the FRAX tool in the patients of the type 2 diabetes mellitus. So treatment, I think not much information is available of treatment. So currently you can use the alendronate in type 1 diabetes, while the denosumab and teriparatide or abaloparatide can be used for the patients of type 2 diabetes. Well, testosterone therapy and diabetic bone disease, we all know that patients of type 2 diabetes are in the state of functional hypogonadism. So if the less than 6 nanomole per liter, then in that case you can treat these patients. If it's 6 to 10, if patient is symptomatic for the androgen deficiency, you can treat, otherwise treatment is not required. So I think I end my presentation by saying here that diabetes is associated with increased fracture risk, more in type 1 diabetes, less in type 2. Bone mineral density is low in type 1 diabetes, and still it is variable in type 2 diabetes. But my impression is that by looking at the in vivo and in vitro studies and micro and at the macro level, that BMD is low in type 2 diabetes also. Bone quality is consistently compromised in diabetes mellitus. Sarcopenia further contributes to increased fracture risk. And so besides all other metabolic controls, I think hyperglycemia control is very, very important. That will help you take care of your reducing the bone fragility, because more the hyperglycemia, more the AGE deposition, and the AGE deposition is directly related to increased fragility fracture. So thank you very much for and also for the opportunity. If there is any question and comment, I'll be happy to answer those. Thank you.
Thanks, Badada sir, for very wonderful deliberation. You have connected well all points, right from gut microbiota, from testosterone level, from hormonal level, for AG and everything, sir. Very nice. Over to Rutul.
We have Dr. Girish Mathur sir and Dr. Ganguly here. So I would like to request them to proceed further.
Thank you, Rutul. And good evening, friends. Now we know thyroid disease and diabetes mellitus are the two most common endocrine disorders encountered in clinical practice. There is a higher than normal prevalence of thyroid dysfunction in diabetic patients, more pronounced in type 1 diabetes. Further, diabetes and thyroid disorders mutually influence each other. On one hand, thyroid hormones contribute to the regulation of carbohydrate metabolism and pancreatic function. And on the other hand, diabetes affects thyroid functions to a variable extent. Therefore, the relationship between thyroid disorders and diabetes mellitus is characterized by a complex interdependent interactions. So to talk more about thyroid and diabetes, the missing link, we have with us Professor Sambit Das, who's Professor of Endocrinology at High Tech Medical College, Bhubaneswar. He's a senior consultant endocrinologist at the Endeavor Clinics and Apollo Sugar Clinics, Bhubaneswar. He has got more than 34 publications in international journals, 18 abstracts, and he's authored 14 chapters and textbooks. He has been the principal investigator in phase 3 trials, 7 phase 3 trials. He's Secretary, Endocrine Society of Odisha, Scientific Secretary, ESICON 2018, Secretary, AIAARO Odisha chapter, and he's member of Endocrine Society of India, ESO, and ITS. Professor Sambit Das, the stage is yours.
Thank you, sir. Thank you for those kind words. Let me first share my slides. Hope my slides are visible.
Yes,
they are. Samit, they are. Yeah. So thank you, sir. So a very good evening, one and all. And at the outset, I must thank the team Diabetes India and Bansi Saboo sir for giving this opportunity. And it is in fact a great honor for me to share the same stage as that with my direct teacher Sanjay Badada sir. So after him, I'll be talking on thyroid and diabetes and the missing links. And it has been aptly discussed by Chairperson sir that diabetes and thyroid disorders are two most common endocrinopathies which we encounter in day in and day out in our clinical practice, and they frequently coexist. And if we see the overall prevalence, though there are many studies to share different prevalences, but the overall prevalence with highest prevalence in type 1 diabetic females and the lowest in type 2 diabetic males. And that may vary from 31.4% in type 1 diabetic female versus 6.9% in type 2 diabetic males. But there is a significant crosstalk, and I'll be discussing about those crosstalks and missing links. So the flow of my presentation would be like I'll be discussing the physiology of the link, like how thyroid and diabetes are interlinked. Second, I'll discuss how thyroid and type 1 diabetes are interlinked. Then I'll discuss thyroid and type 2 diabetes, both in terms of hypothyroidism and hyperthyroidism. Then I'll discuss about the pregnancy implications of gestational diabetes or pregnancy diabetes and the thyroid dysfunction. OADs and thyroid is a very important and emerging concept. And what do the guidelines and the screening guidelines tell us? So this is the flow of things which I'll be discussing. Coming to physiology of the link, I'm not going into details of that because that's a huge topic, but just to tell that thyroid hormone is mostly a catabolic hormone. So in the liver, what it does is gluconeogenesis, decreases the glycogen synthesis and increases the glucose output. So grossly in the liver, it induces more amount of hepatic glucose output. In the peripheral tissue, it increases the glucose transport, but increases the lipolysis also, and increases the glycolysis, and increases the mitochondrial function. So thyroid and glucose are very closely interrelated in terms of the glucose metabolism and the thyroid hormones. Coming to thyroid and type 1 diabetes, I think there is a strong correlation, which I have told initially, that the female with type 1 diabetes has the highest preponderance of any type of thyroid dysfunction. And the prevalence, if we see in this particular data, then the female have around 30.9% of prevalence of hypothyroidism, and the male around 10.1% type 1 diabetes, males and females. And the type 1 diabetes and thyroid disorders, they share a common etiopathogenesis because mostly both are autoimmune pathologies. And there are n number of studies to suggest there is a strong correlation between thyroid disorders and type 1 diabetes. If we see the different studies which I have enumerated, the thyroid autoantibody positivity is to the tune of 2.5 to 32%. Overt hypothyroidism can be up to 15.1%. Subclinical hypothyroidism is also higher. And the total autoimmune thyroid disorders in type 1 diabetes can range from 3.9 to 24%. So there is a significant correlation between thyroid dysfunction in patients with type 1 diabetes. Now the reverse is also true. Till now I have told the presence of autoimmune thyroid disorders in patients with type 1 diabetes. Let us see how the diabetes antibodies, or the antibodies which signify type 1 diabetes, they are present in autoimmune thyroid disease. And if you can see this data, then the autoimmune markers of type 1 diabetes like islet cell antibodies, GAD65, IA2 and IAA antibodies are significantly higher in patients who have autoimmune thyroid disorders. And islet cell antibody are present to the tune of 1.3 to 19% in Graves or in Hashimoto's disease. Now for that reason, there are various guidelines to suggest how we should screen for thyroid disorders in type 1, and even the recent 2021 ADA guidelines is also very clear about screening for type 1 diabetic patients regarding thyroid disorders. So screen type 1 diabetes patients for thyroid disorders with a TSH anti-TPO antibody from the very beginning, and if TSH and anti-TPO antibodies are normal, we can repeat it annually. If anti-TPO antibody is positive, we can do it every 6 monthly or as and when indicated. So these were the current recommendation regarding type 1 diabetes and thyroid dysfunction. Now that was about the strong relation between thyroid disorders and type 1 diabetes. Let us see how thyroid and type 2 diabetes are interrelated, especially in hypothyroidism. Now prevalence of thyroid disorders with type 2 diabetes are also huge, and there are many studies to suggest the prevalence is to the tune of 2.8 to 32%. And the Indian data from Dr. Salam Ranbir et al. From Manipur have reported almost 28% prevalence of hypothyroidism in type 2 diabetic patients, and subclinical hypothyroidism are 16% and overt around 11.4%. Type 2 diabetes in hypothyroidism is also very important because type 2 diabetes, the prevalence in subclinical hypothyroidism is around 5 to 8.6% in different studies. Subclinical hypothyroidism is associated with a greater prevalence of diabetic nephropathy, and it has been shown that patients who have subclinical hypothyroidism, and if they have diabetes, then diabetic nephropathy chances is also higher. The risk of cardiovascular event was significantly increased in type 2 diabetes with subclinical hypothyroidism. Coming to thyroid and type 2 diabetes in terms of hyperthyroidism. Hyperthyroidism is a hypermetabolic state, and Consequently, type 1 diabetes also, or in advanced stages of type 2 diabetes who have hypermetabolism or features may cause diagnostic confusion with typical osmotic symptoms of hyperglycemia. So a type 1 diabetes presenting with polyuria, polydipsia is cachectic and wasted. And similarly, type 2 diabetes with loss of beta cell function for in very advanced condition with hyperglycemia can actually resemble an hypermetabolic state of thyrotoxicosis. So that's a morphological similarities that may happen. Besides that, hyperthyroidism may precipitate in type 1 diabetes patient episodes of diabetic ketoacidosis. Coming to thyroid eye disease and diabetes, the incidence of dysthyroid optic neuropathy resulting in blindness is much higher in diabetic mellitus than in euglycemic population. So the percentage vary from 33% versus 3.9% in non-diabetic population versus diabetic population. Visual recovery is also not good as in euglycemic states, and it is also confirmed. Caution about thiazolidinedione administration and especially pioglitazone use in diabetic patients with active Graves' ophthalmopathy is always a query, and we should be cautious about using these classes of drug in patients who have thyroid eye diseases. Now coming to the third agenda, that is the pregnancy and its implication. Gestational diabetes and thyroid, there is a 3 times increased risk of thyroid disorders in any gestational diabetes mellitus patient, and there are studies to support that. 25% of women with type 1 diabetes may develop postpartum thyroiditis. So that has to be looked for. Combined gestational diabetes and hypothyroidism increases the risk of maternal and fetal outcome. Now, how do we translate into the clinical practice? TSH is PPO antibody determination in type 1 diabetic women planning for pregnancy or at the beginning of the pregnancy, and screening for gestational diabetes which is higher than the normal in trimester specific values in the first part of the pregnancy. Now, another point which is very evolving and interesting is oral anti-diabetic drugs or any anti-hyperglycemic agents and thyroid dysfunction. Now let us see about metformin, and there are data which has emerged that metformin may lead to reduction in the TSH levels in patients with hypothyroidism. No effect on euthyroid patients. So suppose a patient with hypothyroidism, even if he is treated with levothyroxine or not, if you are giving metformin, it has been shown to reduce the TSH level to some extent. Seen highest in the 90 to 180 days after the treatment, and the exact pathological mechanism is not known. Probably the peripheral AMP kinase activation and central inhibition by metformin can reduce the TSH level. And this is a small study, but very interesting, in that after 1 year of metformin therapy, a significant TSH decrease was observed in diabetic patients with hypothyroidism who are either treated or not treated. I've told hypothyroid, even if they are treated or not treated, if you are using metformin, this study has shown there is a significant reduction in the TSH level. No significant change in FT4 was observed in any of this group, and an additional 30% shrinkage in the initial nodule size when metformin was given alone, up to 55% when it was added with levothyroxine. So it has also been shown to reduce the size of the goiter, and also if it is added with levothyroxine. So there is again a bidirectional relationship, and both the therapies complement each other. And there is a point of cross-linking between diabetes and thyroid. So if a person is treated with levothyroxine, it reduces the HbA1c in patients with type 2 diabetes with coexisting subclinical hypothyroidism. And there are studies on subclinical hypothyroidism which has proven this fact. Also, if the treatment with metformin reduces the TSH level in patients with type 2 diabetes, and we have just now discussed that. So both the levothyroxine and metformin can complement each other, but how clinically it translates is a matter of concern. So preclinical animal studies, another point where the anti-diabetic drugs actually cross-link with the thyroid drugs or the thyroid abnormalities. Preclinical animal studies show an association of GLP-1 RA therapy with thyroid C-cell abnormality and parafollicular neoplasm. Caution with GLP-1 receptor agonist in diabetic patients with personal or family history of medullary thyroid cancer in type 2 men have been well documented. Now the last part is, what do the guidelines and screening suggest? Now there are many guidelines. If I tell the recent ADA 2021, then for type 1 diabetic patient, there is a very clear-cut thing. You do a TSH and anti-TPO antibody at the beginning, then do it every yearly thereafter. But for type 2 diabetes, there is no clear-cut guideline how we should proceed in checking the TSH function, how frequently we should do that. A very nice article which was published by Kadalia et al., where they have actually postulated how one should go about screening for thyroid dysfunction in patients with diabetes. Now, if there is all patients with diabetes, we can do a baseline TSH and anti-TPO antibody. If there is thyroid dysfunction, we must treat that. If it is overt, we can treat that. If it is subclinical hypothyroid, we know what are the indications where we need to treat, where there is a symptom, where there is a goiter, when there is an antibody positivity, or when the TSH is more than 10. So these are the clear-cut indications where we should treat. There is no doubt in that. The doubt comes on the right side of the flowchart when the patient is euthyroid and he is diabetic and you have checked the TSH and anti-TPO, that's normal. Now, if it is type 1 diabetes, here also the guideline is clear-cut. You do an annual TSH. But for type 2 diabetes, they proposed a schema where they've told that if the TSH is more than 2 or if anti-TPO antibody is positive, then we can do an annual TSH recommendation. If the TSH is less than 2 and TPO antibody is negative, we can do the test every 3 to 5 yearly and according to the indication. So I think that's a fairly practical approach how we should do. So coming to the conclusion, higher frequency of thyroid disorders in diabetes and vice versa, and we know that diabetes and thyroid disorders are the two most common endocrinopathies, and there is a strong cross links between them. Can have major impact on glycemic control, the thyroid dysfunction. Combined endocrinopathy can have major impact on pregnancy outcome also, we have discussed that. Metformin's role in reducing the TSH is under evaluation, and we must find out the things because there is a widespread use of metformin. Current screening recommendations should be reviewed and modified, especially for type 2 diabetes mellitus patients. So with that, I'll end my talk. Thank you for the patient hearing.
Thank you, Dr. Sambit. That was an excellent, lucid talk and very well explained, very practical talk. Thank you so much. Now I think we can take all the question and answers if there are any. Dr. Raka, are there any questions in the chat box?
No, sir. We have not seen any questions from audience yet. But it was very well connected show by Dr. Badara, Dr. Sambit Das, and Professor Jayant Panda. They have touched almost all aspects which have been in our theoretical way. Dr. Badara has shown some structural programming of bone and all, and their bone health. Dr. Sambit Das has given very well connection with the missing links between thyroid and diabetes. And Professor Jayant Panda is as fluid as he is always on liver cell physiology. Dr. Rutul, you want to ask something? My one question to all of the three speakers, sir, if you take TZDs, use of TZDs, whether it's in bone health, whether it's in hepatic health, and whether it's in thyroid health, how you both three of all how you three comment on the use of very good drug TZDs?
I'm fully with you. The concept of bladder malignancy was a incident which decreased the TZD use a lot, but in Indian context we don't use very high dose of TZD, as you know. So we go for 7.5 maximum 15 milligram TZD, especially pioglitazone, which is available now. We know Rosi is no more available, and we get very good result. It's a affordable drug, it's a effective drug, and then especially the situations where all these comorbidities are blocked, the NFLD, the bone health, also for the metabolic issues like hypothyroid diabetes interface. this is a very nice drug, and I'll agree to you that this should be utilized more for our patients, and the physicians who are listening this discussion should take this message that they should not be very scared about this use. Unless the patient is in heart failure and there is significant fluid retention, edema, and advanced liver disease, and definite contraindications like possibility of the bone fracture. You see, every indication at its higher end, maybe it's not a good drug, but obviously we go for insulin at that point of time, or else while these problems are associated, comfortably we can go for this.
Thank you, sir.
Dr. Jain, I would like to ask a question. How do you feel about SGLT2 inhibitors and incretin-based therapies in the management of diabetes in people with liver disease?
Yeah, that's a very important question, because we know SGLT2 inhibitors are now gaining importance, and in the patients of renal impairment, patients of heart failure, patients obese, we are going for this group of drugs very fluently. In case of NAFLD and diabetes, where the obesity is common comorbidity in both conditions, this is a preference. If we include it in regimen, this targets a common risk factor, that is the weight management. And then if a patient has associated issue like a diabetic kidney disease or maybe a heart failure, then we have to go for this in regimen, even if we are aiding insulin. So this is a very good boon. I have not taken, because specifically for NAFLD doesn't have any advantage, but associated comorbidities like obesity, like other microvascular or macrovascular complications, we have to consider this group of therapy.
And incretin therapies?
Incretin therapy, again, except association of pancreatic disorders. You see, this incretin group of therapy where DPP-4 inhibitors and the GLP-1 agonists are used, preferably in the patient with a history of pancreatitis or chronic pancreatitis, or patient with history of pancreatic diabetes. We have to be a little cautious, or else for NAFLD diabetes association, comfortably we can go with this. There is no contraindication if it is in mild to moderate stage.
Thank you.
So, can I respond?
Yes.
Yeah. So I agree with Dr. Jain, but it is now very well known that management of type 2 diabetes is an art, and every patient is different, and every patient is a different number of parameters: age, sex, microvascular, macrovascular complication, bone health, this and that. So really we have to choose a drug on the basis of that particular patient. We cannot use any drug that it is good, so we can use in all. Like SGLT2 inhibitor is not good for bone, that is very well known. 5-glutathione may be good for so many things, but not good for the bone. It is very well proven beyond doubt. So I think here it is very clear that we should not use any drug as a blanket for any disease duration. There are a lot of number of parameters are there, so we have to choose according to that convenience. And I think RSSBA wheel is one of the good model. I think you can select some of these things, but that also requires some modification because they are not included bone health in that particular one. So these are there, but bioglutamine good drug, no doubt about it, but we should use carefully, especially patient having fracture, female patient, postmenopausal lady, and all these things. Thank you.
Barada sir,
Yes.
we have enough time for discussion. So I want to say that your lecture was awesome, but we were having some short message regarding treatment of bone health. Yeah. I would have better as an audience to get a message from you that what should be the use of bisphosphonates, how we should use, when should we curtail, what is the titrating regime and all. So I am being audience. I want to listen because you are great in that bone health aspect, sir.
Okay, thank you, Dr. Raka. Just I would let me answer in the little more elaborate manner. So first of all, what are the drugs? Those can harm the bone. So we have to avoid those drugs. So that will come under the pioglitazone, and the second drug will come is SGLT2 inhibitor. These two drugs should be avoided. The drugs can be beneficial to the bone health are one is GLP-1 receptor agonist because they are directly acting the osteoblast stimulating, and the DPP-4 inhibitors. The metformin is proven good drug, and other drugs are neutral. You can say sulfonylurea and insulin. They are okay, but if they can cause hypoglycemia, patient may fall, then there is a fracture. So that is the issue. Now coming to the medical management of osteoporosis in patients of type 2 diabetes. So I'll talk theoretically. Then the best drug is actually bone anabolic agents. That is a teriparatide or abaloparatide. Because bone in type 2 diabetes in the basically you can say not in good remodeling stage. That is a low bone turnover state in type 2 diabetes because osteoblast activity is reduced and osteoclast activities increase or something like that. So best is those drugs, but we know that there are certain indications are there to use these teriparatide and abaloparatide because they are limited duration drugs. Not you can use a lifelong these drugs. So in that case, probably currently recommendation is that you can use the bisphosphonate. That is number one drug. It is easy to prescribe once in a year therapy, and whatever few studies are there, they are equally effective. And then, but I said denosumab is one of the best drug for management of type 2 diabetes with osteoporosis, because the denosumab has some advantage on the hyperglycemic control also. That is one advantage. Then it is good for the spine as well as the hip. So that's why the denosumab, if you ask me, given the choice, money is not a problem, then I'll say that you use denosumab. But if your money is problem, best is zoledronate. The severe problem at the spine, you can use the teriparatide or abaloparatide.
Thank you, sir. Yeah. Dr. Sambit, for your wonderful talk, sir. How you relate antibodies and how frequently you go for antibody testing in type 1 diabetic patients for both for thyroid and the TPO antibodies? What should be the protocol? You said around 6 months. Yeah. Every 6 months. If a patient comes once negative, they say that it's almost always negative. Now you said it should be repeated. I'm just asking about that.
Actually, I have shown the strong relationship between autoimmune thyroid disorders and type 1 diabetes. So for any type 1 diabetes, as per the ADA recommendation also and the newer ACE recommendation also. So at the beginning, at the time of diagnosis, we can do a TSH and anti-TPO antibody. If it's negative, then we can still do every 1 year the TSH only, not the anti-TPO. So it's not anti-TPO is to be done once only. Yes. And regarding type 2 diabetes, there is a confusion, but for type 2, I have shown you a algorithm how one should proceed. So if a type 2 diabetic patient comes and you have done a baseline TSH and anti-TPO, if it is normal, then if the TSH is more than 2 or anti-TPO antibody is positive, any one of them, then we should repeat it more frequently like yearly. Otherwise, we can do it every 2 to 3 years.
Thank you, sir.
Dr. Sambit, does a type 2 diabetic with subclinical hypothyroid, I mean, how long do you keep waiting till the TSH goes into the hypothyroid range, or do you treat them earlier? Because given the negative impact of cardiovascular impact of subclinical hypothyroid. So
right. Sir, subclinical hypothyroidism, I must tell 2-3 important things. Like we treat subclinical hypothyroidism only when the following criteria are met. And what are those following criteria? If there are symptoms suggestive of hypothyroidism, if there is a goiter, if the TSH is more than 10, anyhow we have to treat that, or if anti-TPO antibody is positive. Then in those scenarios, we need to start with therapy, and we try to keep the TSH within the normal limits. Because as you have rightly told that subclinical hypothyroidism, why we treat? Because they have a higher chances of progressing into overt hypothyroidism, and they have also high chances of cardiovascular and the lipid abnormality in the future. But another point which I just wanted to highlight is that it has been shown that if the people are more than 70 years of age, that is elderly, if you are treating subclinical hypothyroidism, then in fact the mortality is higher. But if the age is less than 70 years, the advantages are there. So for an elderly patient, we should not be very aggressive in treating, especially the subclinical hypothyroidism.
So why there is association of nephropathy more in subclinical hypothyroidism? You showed one slide.
Yeah, it has been shown. In fact, there are many studies which have shown that both subclinical and overt hypothyroidism has been associated with nephropathy because of some hemodynamic changes. And it has also been shown that in patients who have overt hypothyroidism, by controlling the hypothyroidism, the renal function improves. So that's the hemodynamic changes basically mostly.
Over to Ganguly, sir.
Thank you. That's all.
Dr. Ganguly, we have any questions from the audience?
I don't think so. There are any questions.
No questions.
Chat box at all.
Yes, sir. Dr. Rutul?
Yes, we don't have any question in the chat box, and we can move further to the next session. And Dr. Vidisha is the reporter for the next session. I will hand over to Dr. Vidisha.
Thank you all.
Thank you. Thank you all. Thank you all. Very well done. Thank you, Bansi sir. Thank you, Rutul.
Thank you. Thank you, everyone.
Thank you, Ganguly sir.
Thank you. Bye-bye.
Bye-bye, sir.
Vidisha ma'am?
Yes. Just a second.
You can start the session.
Okay. So good evening, everyone. I am Dr. Vidisha Patel. And first of all, I would like to thank Dr. Bansi Sabu sir to give me an opportunity to be a part of the conference. And I guess we are running ahead the session. So just give me 2 minutes if we have the chairpersons and the speakers available in the hall.
Hello, Vidisha ma'am?
Hello, yes, tell me.
Ma'am, speakers are not joined yet. So we have Guillermo sir's pre-recording session. So we can start with that, this session.
Pre-recording session of whom?
Guillermo sir.
Okay, let me get back to you in 2 minutes, okay? Yeah.
Dr. Vidisha. Dr. Vidisha, please start with the Dr. Guillermo's session, as it is pre-recorded and it is in this symposium only, International Speakers Symposium only. So we can start.
Okay,
with
then
this.
we can do that.
Yes.
Fine, not an
Yes,
issue.
and till that, all
Sure,
other
sure,
speakers will
definitely.
join. Yes.
So Rutul,
Okay,
I
fine.
can see only you and Vidisha is there, but the last session was Raka is also there. So because we have 10 minutes and the next speakers are international speaker program, and we are going to, Rakesh is also there. So
Yes,
we
sir.
will be having the next right at 6:30, and I'm sure the chairperson and the speakers, they will be joining at right time. So that is what they are supposed to, and I'll be also joining in the hall A only. So there it is going on. We are going to have 4 eminent persons from all over the world. I can tell you that Dr. Philip Hom, who is who in the world, Dr. Desmond, who was the past president of American Diabetic Association. Guillermo is a president-elect of American Diabetic Association. So you can see in this same session, you have immediate past president and the president-elect. And then we have Dr. Harpreet Bajaj, a global Indian who is from Canada, who was from Delhi. And so you will be introducing, I'm sure the chairperson will be introducing once they will be joining all the 4 faculty persons, because it's a live program, so we can't have. But we have one very eminent person from Ahmedabad, who is Dr. V.K. Abhichandani, my very close friend, elderly brother to me. And we can have some discussion, because till we get another 10 minutes, we can definitely have a discussion, because these 4 topics which are very interesting and that I want to discuss for the sake of till we get speakers in line, because Dr. Desmond is going to talk about the type 1 diabetes. Dr. Philip Hom is an eminent personality. As I told you, he is a chief investigator and principal investigator of many of international trials. And Dr. Philip is going to talk in insulin in its 2nd century. So, 100 years is already completed, and what we are going to see in future. So, and Desmond is going to talk that how we can improve the life of type 1 diabetes with newer technology. That's a second important point. Then before, one is going to talk about the 100 years, after 100 years, what is going to happen. So Guillermo is talk about the overall prevention program, why we need insulin for type 2. Let us think of something which we can prevent for type 2 diabetes. And then Harpreet is going to talk, because his favorite topic is GLP-1. As favorite topic of Vidisha also, the GLP-1 is always very close to her heart. So we always GLP-1 to start with the patients to whom we can prevent the diabetes. At least reversal of diabetes can be done in some of the patients who are type 2 diabetes, who had come to us before. I mean, they are obese, overweight, with less than 5 or 7 years of diabetes. So I just start with Dr. V.K. Abhichandani, that what you think in next 100 years, where insulin will be. I mean, I'll be just asking 3 of you one question, and then we will have the second session.
First of all, thank you for your kind words.
You unmute yourself. What do you think where it will be after, I mean, the 2nd decade, 2nd century of insulin, where we will be? Do you think it will be still injectable?
I look
You are, sir, muted.
No, I'm not muted. I have unmuted myself.
No. Yes, perfect. Yes, sorry.
Yeah. So, Bansi, again, thank you very much for making us a part of this great program. And over next 100 years, may you live that long to realize many, many big achievements, much bigger than what you have done so far. And I foresee insulin in oral form, in basal insulin once a week, which is probably come to us very shortly. Maybe an inhalation form of insulin, which is going to be lung friendly, highly technically superior to earlier versions, and ultra short acting smart insulins, which would probably sense sugars and then only inject. So pellet therapy for insulin is also a future possibility. Implanted pellets, just like we have for some of the, I believe there is a exenatide pellet formulation available in the market.
So that's great, really. But I think this smart insulin, maybe after a decade, in first decade, we are going to have oral inhaled insulin, once in a week injection, something like that. In next decade, we are going to have the smart insulin, as you are rightly saying, they are glucose sensed insulin, then maybe oral insulin or pellet. But I don't know, I'm really very excited to listen Dr. Philip Hom, who is going to talk for the next 100 years what he is predicting, because what we are predicting maybe in another 10 years or 15 years what we are going to have, but I don't know in next 100 years what it could be. So now Rakesh is a close friend of mine who is from Jaipur, and he's also very actively working for type 1 diabetes and technology also. So Dr. Rakesh, what do you think that in India, how the technology can improve the life of type 1 diabetic patients? What Desmond is going to talk for that.
Right. So thank you, sir. Thank you for giving this opportunity. And it will be really enlightening to hear these Indian speakers in the next 1 hour. But as you asked me, what I can pursue or I can see at my end is that in India, the technology is evolving very fast. Now, with the advent of the high-speed network, we have internet facility available even in the rural India, which was not earlier available there. So I think that the major change that will happen in the field of type 1 diabetes would be the use of telemedicine at first, because the type 1 diabetic patients were earlier left to the mercy of tracks and at most GPs which were available there, and they were very badly managed. If you talk about very deep in the rural areas, so now those people having the facility of internet and the different apps that they have, they will be able to connect with doctors like you and many other eminent doctors from all over India, and now we can give them the treatment that they deserve. So I think that is the biggest achievement in the technical field that we have got in the last few years, and probably will do much better in the upcoming years. And moreover, if we talk about the other developments in the field of technology, then as you are very much aware, there are so many monitoring devices, better and better devices that are available now, the newer and newer pumps that are available now, the closed circuit that we have now. But all these things probably may not be available to the masses because of the cost factor. But probably technology bridging the gap between the patients and the doctors would be the most important thing that we can probably see in the very near future.
Raka, what do you think about the prevention, update on a diabetes prevention with Dr. Guillermo is going to talk. We have Dr. Philip Hom here already joined. Welcome, sir. And we are just waiting for other two to join. So till that we are discussing. So now over to Dr. Raka. What do you think that diabetes prevention, how is it a myth or it's really a fact? What do you think that yes, diabetes can be prevented? Unmute yourself, unmute.
Very sorry, sir. You are visionary, sir, regarding reversal of diabetes, remission of diabetes. You have given elaborate lectures, and we at this platform at Chhattisgarh level, at state level, we are your shishya, and we are all are doing all these things in front of you only. So I really believe that remission and reversal of diabetes it's a true thing. It's not at all myth, and we have done it, and many more doctors and many more in this forum believe in this thought that we are doing this and we'll be able to do it because of so many reasons. Because we have calculated the metabolism of fat, the calculation of mathematics of fat and weight calculation have been done. We have calculated how water and CO2 becomes aldehyde, and how this aldehyde picture can be taken in a better panorama and bigger panorama, and how you can be decisive of your fat and weight balance and their insulin resistance. The main key of all kind of disease worldwide, main key of this disease worldwide is insulin resistance. And in type 2 diabetes, you have given such vision to us. And thank you for asking me, because I am working in this diabetes reversal since last so many years, and I am happy that we are getting patients from where we have simple calculations of negative anti-gravity exercises, use of anti-gravity exercise post-prandial, and we are getting such results in decreasing insulin level. Every time we are able to de-escalate sulfonylureas. So this is the question you asked directly to me, but I was very much interested to answer about your first questions regarding future of insulin, sir. I will love to see insulin named Bansi insulin from Gujarat will be which will come as a single oral pill, and it will be very friendly to our Indian patients, poor patients, and I can foresee that someday you will come with such kind of insulin to all of us and our
We
patients.
all should work, I think, for prevention. That is our major motto, and
Yes.
more with the reversal. I don't know whether we all can do the basic research. We all are clinicians. And what we can do is more research in terms of how we can prevent the diabetes. Yes, Rakesh, you want to make some comment, and then already
Sir,
Dr.
actually,
Right, so we can start the next session.
I'm sorry to disagree with Dr. Raka. I have a problem with this terminology, reversal and remission. I personally feel that it's like preventing aging. You cannot prevent aging from happening. You cannot, make some elderly person young. So I think that you can probably make a diabetic patient euglycemic without the use of medicines. But then if you call it as a remission, then that gives a false belief in the patient that he has, he has got cure of diabetes. And that probably is missing. That's
No,
my
so
personal
Rakesh,
opinion.
I
You
just
might
want to,
disagree with that.
I agree with you,
Yeah.
but the word which they had used, the remission or the reversal, that in a physiology, in physiology or pathology, we understood that first phase of insulin secretion goes away as soon as somebody develops ICD or diabetes, type 2 diabetes. They had used reversal word or remission when a person first phase of insulin secretion comes back. So they have done with the clamp study and with that, and if first phase had come back, that means it is actually the person is having reversal. If you are getting without any medicine and on diet, and if sugar is less than 6.5, you will say diabetes is well controlled without medications, and he is only on lifestyle modification. But if you can get first phase of insulin secretion back, then you can say, yes, there is a reversal. Now, Vidisha, I think you can start with the two chairperson if they had come, or you want to make any comment on GLP-1, because that's a Harpreet Bajaj who is going to talk. And the other two are from US, and Dr. Harpreet is from Canada. So that might be the reason they might be joining maybe another 5-10 minutes. I'm trying to contact them. Until that, you can invite both the chairperson to introduce Dr.
Sure, sir. Thank you so much. And it was nice to brush up before the sessions start. So welcome you all for the amazing International Speakers Symposium, for which I would like to invite two chairpersons, and it is my honor to invite Dr. V.K. Abhichandani, sir, from Ahmedabad, and Dr. Rakesh Parikh from Jaipur. Over to you, sir.
Thank you very much. And do I begin by inviting the honorable first speaker? Or do we wait?
You're early. You're early. Got 4 minutes yet, I think.
We can start.
Okay.
Sir. Yes, sir.
So it gives me great pleasure to invite Dr. Philip Home, Emeritus Professor of Diabetes Medicine, Translational and Clinical Research Institute, Newcastle University, UK. And he has been past president of IDF Europe, past vice president of IDF. And yes, sir, we really look forward to learning from you in your great lecture, what is in store for all of us regarding insulin therapy as it enters the second century of its existence. It remains a gold standard, and we are excited to learn about the developments in the coming next 100 years. I mean, that's a futuristic talk we look forward to. and learning about probably once a week basal insulins and smarter insulins, oral insulins, everything we look forward. Thank you very much, and I welcome you to deliver your talk.
Thank you very much. I need to share my screen, but yes, I can now do it. Thank you. And I have protected the left side of my screen. I'm going to be talking about insulin futures, as you say, and it's a pleasure to be back talking about the future of insulin therapy, the future of insulin therapy into, of course, its second century. This is quite a big talk. I've got quite a lot to say, so I'll get on fairly quickly. Just to note that I do not have any dualities of interest for the products I'm going to talk about, the potential products, but I do, of course, for the comparators which are on the market already. So let's think about what we might talk about here. And first of all, what I'm not going to talk about, there are areas in insulin therapy such as prevention, such as insulin regimens and education materials, transplantation technology, islets and regenerative medicine, gene therapy and closed loop systems. These are not the things I'm going to talk about. I'm going to be talking about insulin itself and getting insulin into our patients to their benefit. So the things at the bottom here are the subject of my current talk. We need, however, to think about what we're trying to achieve, and some of the problems we have for insulin have to be overcome. And in particular, minute-to-minute regulation to govern changing need, eating, exercise, and the like, hour-to-hour regulation to changing need post-exercise, post-hypoglycemia, concomitant illness, overall calorie intake. We need a flat basal insulin level, except in the post-absorptive state, and we need a fast and reflex incretin response to calorie consumption, not regulated by glucose. But glucose and amino acid regulation, of course, after a meal. And presently for insulin, except for basal insulin therapy, perhaps, we are unable to provide any of these with current insulin therapy. As a result, no one with type 1 diabetes attains normoglycemia, 4 to 7.5 millimoles per liter, and average daily plasma glucose based on HbA1c in type 1 diabetes is about 50% above normal. Here's what we need for basal insulin delivery. As I've said already, here is the glucose under flat control during the night, and here's how it's achieved with feedback and absolutely flat basal insulin delivery. This is the case with normoglycemia. If you have people who are even mildly hyperglycemic, there are changes during the night. Then we have the mealtime profile. Mealtime insulin delivery, a sharp rise, 50%, 60% increase in just 15 minutes in insulin concentrations to a peak at 30 minutes and beyond, and declining, and this regulated by glucose to baseline at 4 hours. So we're looking at a flat profile and a sharp, indeed, upward profile driven by incretins, driven by reflexes and regulation on the way down, but all this regulated on a minute-to-minute basis according to need. If I was to leave this computer now and run out to the road outside, run back again and sit down, my insulin secretion will have fallen by about 50%. It's very rapidly regulated in response to calorie intake, physical activity, and indeed acute stress. And that, of course, can't happen once you've given an insulin depot. That's also true for basal insulins. In a few hours, post-hypoglycemia with development of concomitant illness, taking alcohol with some medications or increase in overall calorie intake, we will see a change in insulin need in no time at all. And these things somehow we need to get into our insulin preparations in the coming future. I'm not going to talk about closed loop, but you might say to me, well, what about closed loop? Well, here's a state-of-the-art figure taken from a review in Diabetologia only a couple of months ago. Just look at the basal insulin delivery. It's a series of little humps. It's not flat at all during the night. And this is classic feedback over control with oscillation, and it occurs by the need to sense glucose subcutaneously rather than the circulation, and to deliver insulin from subcutaneous tissue rather than intravenously. So no, we can't do it with closed loop systems either. So first of all, let us look at micro and nanotechnologies. And this section will be fairly brief. Actually, they're long familiar in diabetes. They're not particularly new. The insulin hexamer itself, of course, which we inject in our regular preparations, is 5 nanometers in diameter, and the insulin analogs, which are developed from meals, dimers, and monomers, are about half that. So we've engineered down to about 2.5 nanometers to enhance diffusion and capillary wall permutation. Insulin degludec, it forms multi-hexamers subcutaneous